Good day, ladies and gentlemen. Hi to Europe. Hi to everyone that are online connected. I think this video from the Ministry of Health really deserves one applause. So hi to the guests here locally in Croatia. Dear representatives of European Commission who are connected online, representatives of European Parliament, dear Minister of Health of Republic of Croatia, dear Director of National Public Health Institute, distinguished guests, speakers, international supporters, and of course, dear partners in health. We are really delighted to welcome you here on behalf of Health Hub, a think tank for healthcare and healthcare industry, and Croatian Ministry of Health, on the occasion of EU Beating Cancer Plan, Next Generation EU, National Cancer Plan in Croatia, and National Lung Cancer Screening Program. On this occasion, we decided to lead this today's initiative, High-Level Policy Forum, Addressing Cancer Injustice in CEE countries. My name is Anita Galic. I'm the CEO of Health Hub, and I will be your host today. As we mentioned, on the occasion of Beating Cancer Plan, many cancer plans all over Europe, we actually, together with the Ministry of Health of Croatia, decided to lead today's event, but also a big thank to our supporters and partners today, as following: European Cancer Organization, European Cancer Patient Coalition, Center for Innovation in Medicine, INOMED from Romania, FPA, European Federation of Pharmaceutical Industry and Association, CCOG, Central European Collaborative Oncology Group, and a huge support from the European Commission and European Parliament, especially from the local offices here in Croatia. So as EU Beating Cancer Plan highlights, a number of indicators really show major differences in cancer prevention and care between and within the member states. These inequalities, as it is mentioned by the President of European Commission, but also the Commissioner for Health, Stella Kyriakides, are really unacceptable in today's Europe that deserves equal opportunities for every European citizen. We will actually continue after this high-level policy forum to address this cancer injustice and offer some constructive solutions and examples, best practice examples, in special policy report that will be led by Ministry of Health and Health Hub. So stay tuned also after this conference. With this event, we would also like to share the best practices within the EU member states, and we're especially proud that a small and the youngest member state, Croatia, actually led a really unique and nationwide lung cancer screening program, despite pandemics, despite all the challenges. Hopefully it will serve as a role model for other member states to implement this lung cancer screening program, especially due to the fact that this is the biggest European cancer killer. Also, we would like to highlight European Commission's initiative, especially in prevention, in ensuring equal access to innovations between the member states. So we tackle this issue also in today's agenda. But first, let's give a very warm welcome for our co-organizer, the Croatian Minister of Health, Professor Vili Beroš, that will speak in one of the member state official languages in Croatian, but you can see the translation in English. Professor Beroš, welcome here, and the stage is yours. Let's give a warm welcome here also.
Hvala Anita, poštovane dame i gospodo, čast mi biti tu, iako su današnje obaveze brojne, ali snažno smo odlučili dati podršku ovom forumu, jer doista vjerujemo u ideju i činjenicu da je zajedništvo, poglavito glede onkološke skrbi, ono oko čega moramo svi zajedno razgovarati. Dakle, na tragu našeg slogana zdravlje je prvo, zahvaljujem naše Republike Hrvatske, a danas i šire, osiguramo učinkovitu, dostupnu i modernu zdravstvenu skrb. Bilo je lijepo gledati ovaj video uradak koji pokazuje doista sve ono što smo napravili do sada, ali potpuno jasno da u budućnosti moramo još i više. Suorganizacijom ovog važnog High Level Policy foruma na temu nejednakosti u onkološkoj skrbi za države srednje i istočne Europe želimo poslati snažnu poruku zajedništva i Europe koja raste, Europe koja povezuje, okuplja, štiti svoje građane, Europe koja je asertivna i otvorena prema susjedstvu i globalno. Upravo su ovi postulati bili temeljni stupovi povijesti hrvatskog predsjedanja Europskom unijom i zato se ova konferencija danas i organizira na mjestu odakle je krenula, u ne tako idealnim uvjetima pandemije, konkretna europska akcija za borbu protiv raka. Prisjetimo se, 2020. godine, osim po globalnoj krizi uzrokovanoj koronavirusom, ostaće ipak povijesno zapisana u zdravstvenoj diplomaciji kao godina važnih političkih iskoraka u interesu boljitka oboljelih od raka. U iščekivanju predsjedanja Lijepe naše Vijećem Europske unije osluškivali smo glasove hrvatskih i europskih građana te uvrstili onkološku skrb na zdravstvenu agendu našeg predsjedanja, vodeći računa o političkoj prioritizaciji raka unatoč pandemiji koronavirusa, a pritom smo do kraja 2020. godine intenzivirali i naše aktivnosti u dovršavanju nacionalnog strateškog okvira protiv raka u Republici Hrvatskoj. Nipošto nismo zaboravili naše onkološke bolesnike, nego smo ostavili trajni trag za njihovu zdraviju budućnost sa europskim i hrvatskim planom borbe protiv zloćudnih bolesti. Ministarstvo zdravstva je vrlo aktivno promicalo važnost onkoloških tema i podržalo svojim sudjelovanjem u brojnim inicijativama Europski plan protiv raka od prvog javnog obraćanja EU povjerenice za zdravstvo do zdravstveno-političkih dijaloga na brojnim ministarskim konferencijama. Bili smo domaćini brojnim europskim zdravstvenim delegacijama i udruženjima pacijenata koji su govorili o potrebi jednake dostupnosti onkološke skrbi svim europskim građanima neovisno gdje žive. Poruka o važnosti adresiranja nejednakosti u onkološkoj skrbi koju su obol dali Ministarstvo zdravstva, Vlada i naši eurozastupnici, danas je sastavni dio velike europske vizije i svih akcijskih i izvedbenih planova koji imaju za cilj maligne bolesti pretvoriti u izlječive ili kronične bolesti koje ne uzimaju dragocjene ljudske živote, posebice kada se uzme u obzir da je gotovo 50% raka moguće spriječiti pravilnim životnim navikama i ranom dijagnostikom. Uzevši u obzir da je Hrvatska neprepoznata globalna koljevka zdravstvene pismenosti i da imamo snažnu ostavštinu profesora dr. Andrije Štampara, jednog od utemeljitelja Svjetske zdravstvene organizacije, ovakve konferencije su prilika da zajedničkim međunarodnim dijalogom pokažemo svjetlo na kraju tunela za države koje nemaju jednake uvjete i mogućnosti dijagnostike i liječenja te lošije ishode liječenja onkoloških bolesnika. Unatoč svim izazovima imamo globalno jedan od najsuvremenijih planova protiv raka koji se temelji na ishodima liječenja. Na EU razini smo prvi pokrenuli nacionalni program ranog otkrivanja raka pluća kojeg provodimo gotovo već 2 godine. Unatoč potresima i pandemiji implementirali smo nadalje e-karton koji je dodana vrijednost za bolju skrb onkološkim, ali i drugim pacijentima i radimo onkološku uputnicu i još neke druge iskorake. Osnažujemo prevenciju. Reformskim mjerama i preventivnim zdravstvenim pregledima borit ćemo se protiv nezaraznih kroničnih bolesti, među kojima je naravno i rak. I to radimo ukorak s Europom koja je iznjedrila inicijativu Healthier Together za borbu protiv nezaraznih kroničnih bolesti i EU plan protiv raka. Kao što smo pozvali tijekom predstavljanja naše reforme, želim i danas prenijeti glasnu poruku i poziv svima na akciju, svima onima koji žele dati svoj doprinos zdravoj sutrašnjici. Stoga važno je okupljati, ne izazivati podjele. Važno je inspirirati i učiti od najboljih kako bi svi jednako napredovali. Važno je iskoristiti potencijal europske vizije i europske obitelji kako bismo imali zdraviju budućnost za čitavu Europsku uniju. Važno je investirati u zdravstveno prosvjećivanje kako bismo imali građane koji se odazivaju na preventivne preglede i spašavaju svoje živote na vrijeme. Važno je u duhu tehnološkog razvoja integrirati na vrijeme digitalna rješenja koja iskorištavaju na pametan način podatke u interesu što boljih ishoda liječenja. Važno je iznositi probleme s kojima se suočava čak i Europska unija u smislu loše zdravstvene statistike, ali i za njih ponuditi konstruktivna rješenja. I zato smo danas ovdje, te smo ponosni biti regionalni lider u ovakvom zdravstvenom političkom narativu uz mnogobrojne respektabilne partnere od Europske komisije i Europskog parlamenta do brojnih udruženja civilnih društva i onkoloških pacijenata kako bismo i mi dali svoj obol misiji zdrave, stvarne, osnažene i digitalne Europe u kojoj građani što manje umiru od onkoloških bolesti. Evo, zahvaljujem na pozivu, doista mi je čast biti tu, snažno podupiremo ovu inicijativu i pozivam vas sve da se pridružite istoj. Hvala vam lijepo.
Thank you, Professor Beros, Minister of Health. It is really important to have the support from the health authorities, especially in leading this kind of narrative that gathers all the surrounding member states, but also, I would say, on European level, that the countries which have maybe at this moment poor outcomes to somehow strengthen the narrative that can contribute to the really better care of oncology patients. During the pandemics, we had a lot of challenges for oncology patients, and it was really an honor for Health Hub to be a partner of the Pan-European initiative that was led by European Cancer Organization. So let's hear also welcome from the Director, CEO of European Cancer Organization, Mr. Mike Morrissey.
Hi everyone, welcome to Brussels. I'm Mike Morrissey, I'm Chief Executive of the European Cancer Organization, and I'm really sorry that I can't be with you in Zagreb today for this high-level conference on addressing inequalities in Central and Eastern Europe. I'm really sorry I can't be there because it's a subject that is very close to the hearts of everybody that works at the European Cancer Organization. We think that the Europe's Beating Cancer Plan, which is currently being implemented by the EU Commission, represents a once-in-a-lifetime opportunity for us to throw a spotlight on the inequalities that exist in cancer care in Central and Eastern Europe if we compare to other parts of the European Union, but also, and more importantly, to do something about it, to get the investment that's needed and the understanding that's needed in national and local healthcare systems to raise their game and to improve the care that they give to their citizens. We think that there are many types of inequalities, and what we try to do in our work is to explain to people that inequalities in cancer care don't need to exist, that we can do something about it. One of the tough things that's been happening on inequalities that already existed in Central and Eastern Europe has been, in the last few years, two crises have made it worse. One, the COVID pandemic. There were so many people who had cancer and didn't know it at the time during the pandemic because they were told to stay at home. And then we've seen, on top of that problem, the Ukraine war and refugees coming from Ukraine to Poland, Moldova, Czech Republic, many countries in Central and Eastern Europe, putting extra strain on the healthcare systems there. We think that to make our best case on the question of inequalities, we need to have data. And at the European Cancer Organization, we have two resources that can help with providing data on inequalities. The first one is about COVID. And we had a Time to Act campaign, which includes a data navigator. You can find that data navigator at timetoactcancer.com. It's data from 27 countries. It's data on different tumor types of COVID. Have a look at timetoactcancer.com and see the impact of COVID on cancer. And also, we're launching this month something called the European Cancer Pulse. If you go to europeancancerpulse.org, you'll see that there's a public-facing tool to be able for you to compare countries between each other and to see what's going on within countries on issues such as gender and age. So we hope at the European Cancer Organization we're part of the solution, that we're part of trying to throw a spotlight on the inequalities that exist in Central and Eastern Europe. I wish you all the best for this fantastic conference that's ahead of you, and you can contact us anytime. Find us on our website, europeancancer.org.
So big thanks to Mike Morrissey and the European Cancer Organization. They are always really at the forefront of the trends regarding oncology health policies, and it's quite really an honor to continuously collaborate with them, such as throughout Time to Act campaign, but also today's initiative. Mike will later on describe in more details about the ECHO's initiatives in cancer care. It is really an honor to welcome the representative of European Parliament, especially due to the fact that the voice of the people, of the European citizens, is really important, and the representatives of European Parliament are the voice of the people, elected by the people. And we are proud that our member of European Parliament, Assistant Professor Tomislav Sokol, is one of most active parliamentaries in the EPs, and he is quite engaged in reducing the inequalities among member states. So can we hear Professor Sokol? He is online, connected.
I hope you can hear me and see me. So thank you very much for inviting me to this important conference, especially because it puts an emphasis on a very important issue. I believe the most important health issue in the European Union, which European Union should resolve and should be more actively engaged in resolving. Of course, when we speak of inequalities in cancer care, we already have a lot of data on that, which shows us that there are almost 40% bigger chances of dying from cancer if you get cancer in one of the eastern member states of the European Union, Central Eastern, when compared to the western part of the European Union. So this is definitely a major issue, and an issue which needs to be resolved, where the European Union can do a lot to help. Of course, when we speak of healthcare in general, we know that healthcare is primarily national competence, that financing, organization, and management of healthcare is competence of the EU member states, while the European Union can support national policies, but it cannot legally harmonize or unify different healthcare policies. And this is actually one of the reasons why we have these disparities, these differences. But still, what is important is that because of two issues, healthcare has, from a marginal topic, become one of the most important topics in the EU. Of course, one of these topics is COVID-19. I do not have to explain additionally why this has put healthcare into the limelight, but also Europe's Beating Cancer Plan. So these are two developments which have made healthcare become one of the most important topics in the Brussels bubble, in the European institutions, when compared to the previous years that it was really, really marginal. So when we discuss what European Union has done in the area of Europe's Beating Cancer Plan, I won't go into too much detail now because I have a separate presentation a bit afterwards, but I would like to emphasize the fact that the Europe's Beating Cancer Plan is the first comprehensive plan to beat cancer, which includes both prevention, early detection, treatment, but also afterlife and aftercare of cancer survivors. So all of these phases, so not just treatment, which is usually one of the most important topics, which is most often discussed, but everything really from prevention to afterlife, and also research and innovation. Research related to new types of cancer medicines and cancer treatment in general. So this is a very comprehensive plan, but what is also very important, unlike many other European Union plans, here we have concrete indicators, concrete benchmarks, concrete timetables, concrete action plan for implementation, and concrete funding. Because with many European Union, but not just European Union, but also national strategies and plans, the problem is that these are in many cases just wish lists, but without concrete instruments how to actually implement this. With Europe's Beating Cancer Plan, it's not the case, because here we have a really whole framework how best we can implement it, and very important is also the finding of more than 4 billion euros, which is allocated in the European budget. Of course, the plan is not perfect. The European Parliament made its report, which was made by the Special Committee on Beating Cancer that I was a member of, where I opposed almost 150 amendments, which were more or less all accepted. So we emphasized some problems in the area of report and highlighted the fact that it should be more precise in certain areas, especially related to treatment, because the really big focus is on research, prevention, and early detection. But we believe that also some things related to treatment should be better structured and should be stronger and more precise. And also for afterlife of cancer survivors, especially when they face discrimination, when trying to access financial services, when they have to pay higher premiums for life insurance and things like that. So we made our recommendations on how to improve the plan. Which I think is very important. And now we have already started with implementation and believe that this will be a major breakthrough in terms of enhancing and improving health outcomes related to cancer. Also, one additional initiative that I would like to mention that I was working on, and then I will finish with this opening statement, is also the fact that I was a rapporteur in the regional committee, Regional Development Committee of the European Parliament, which is in charge of cohesion policy, with the topic of how to use European Union cohesion policy, so European Union structural funds, to reduce inequalities in terms of healthcare provision. And there I highlighted some very important issues, but the most important thing is that when we have all of this funding at our disposal, which are now record-breaking amounts, especially in Croatia, but we should actually be more careful about how these funds are spent and whether spending of these funds actually leads to better health outcomes. So I think that we need much better framework in terms of seeing whether the funding that we are spending from EU budget actually contributes to health outcomes and how this can be improved. I think there is a lot of room for improvement there, and this is also one very important issue that we are now discussing on the European level. So thank you very much. As I said, since I will be having a separate intervention a bit afterwards, I won't go into too much details. Thank you very much again for inviting me, also for including all important stakeholders, both from national and European level, especially patient organizations and pharma industry. I think they are very important. We cannot do anything without them. And I look forward to hearing other presentations and also to engaging in more detail about what concrete initiatives we are conducting now on European level to reduce inequalities which exist. Thank you very much.
Thank you, Professor Sokol. Let's give him a warm applause for his welcome speech. Later on, we are excited to hear more, especially about your efforts on using of European Social Fund and Cohesion Fund for reducing cancer inequalities. We recently had a presentation of your Croatian reform of healthcare system, and very often we used sport terminology during this presentation. So I will again use this sport terminology when we have successful athletes, Olympians, world champions. Despite the fact that they have won a medal on a daily basis, they need to continue to work out, to invest in themselves. So we never must not stop to actually repeat and somehow have as a kind of mantra how much important is to have a EU beating cancer plan that is also dedicated to reduce the cancer injustice and cancer inequalities. It is very important to have support from the European Commission in this kind of narrative, which we need to repeat on a weekly basis or a daily for sure. So now we can present the videos of the President of the European Commission, Dr. Ursula von der Leyen, the Health Commissioner, Stella Kyriakides, and the Chair, the lead of the Croatian Representative Office of European Commission, Ognjan Zlatev.
In 2020, while we were all fighting against the COVID-19 pandemic, many of us were fighting a silent battle, a battle against cancer. We lost more than 1 million Europeans to this disease, parents, friends, loved ones. And sadly, the number of cases is on the rise. And this is why we present Europe's Beating Cancer Plan. We have set ourselves ambitious goals. We want to save lives through prevention. We want to detect cancer as early as possible. We want to ensure access to the highest standards of diagnosis and treatment. And we want to improve the quality of life of cancer patients and survivors. On our way towards reaching those goals, we define clear targets and significant funding, in particular through our research program Horizon Europe. Our overarching matter of concern is to provide to citizens equal access across the European Union to modern technologies of detection and treatment, to the same high standards of care, and to comprehensive support to patients and their families. The fight of those battling cancer is our fight as well in Europe.
Now we can see the video of Stella Kyriakides.
The European Cancer Plan through EU for Health will be supporting actions across the entire cancer pathway, from prevention to early detection, from diagnosis and treatment, from quality of life of cancer patients, of survivors, to those living with metastatic disease. The pandemic has shown that coordinated action is the best way forward in order for us to be able to do this. And a key lesson that we must take away from this crisis, because out of crisis come opportunities for us to learn, is that really applies to all areas of healthcare, including cancer. And cancer patients have been hugely affected by COVID-19. The pandemic has disrupted their treatments, has delayed screening, has created anxiety and uncertainty, has paused clinical trials, has affected access to medicines. And we need to address this and through this plan in a holistic way. And we also want to take advantage of the vast potential of digital technologies, including using our Horizon Europe Cancer Research Mission, because cancer patients should have the same possibilities wherever they live in the EU. And we need to address inequalities. We cannot have first or second class cancer patients in the EU.
And
In
the last one.
2020, while we were fighting the COVID-19 pandemic, many of us were fighting another silent battle, the battle against cancer. In 2020, 2,700,000 people in the European Union were diagnosed with it, and we lost 1,300,000 Europeans to this disease. Sadly, the number of cases is on the rise. The fight of those battling cancer is our own fight as well in Europe. In 2021, the von der Leyen Commission presented Europe's Beating Cancer Plan, a main priority in the area of health. This anthropocentric plan addresses all angles: prevention, diagnosis, treatment, and survivorship. The plan is based on a health in all policies approach. It pulls all strengths together under a common goal: beating cancer. It is about health, but beyond health policy, a whole of society effort. Over the coming years, the Europe Beating Cancer Plan will focus on research and innovation. It will tap into the potential that the digitalization and the new technologies offer. What is more, it will mobilize financial instruments to support member states. The Recovery and Resilience Facility has a budget of 672.5 billion euro. This is an all non-repayable support and loans. can be used for investments in health infrastructure, equipment, digital transformation of healthcare, or manufacturing capacity for medicine and medical devices. Member states are responsible for setting priorities within this instrument on the basis of their needs and for carrying out the program's projects. The Commission strongly encourages Member States to make full use of these options to implement the measures included in the cancer plan. Europe accounts for 1/10 of the world's population, but a quarter of the world's cancer cases. By 2035, cases are set to increase by almost 25%, making it the leading cause of death in the European Union. In a strong European health union, cancer is a shared political, operational, and scientific priority. And this holistic approach is what the Commission will push for in future as well, so that we can defeat the cancer together.
Please applause for the representatives of European Commission, the leadership of the European Commission. And we can continue, as Professor Sokol said, he will have quite more detailed speech about the perspective of European Parliament on cancer care, especially when we speak about tackling cancer inequalities and cancer injustice. Just to say, it's quite impressive to have Europe connected online today. This is one of the, I would say, advantages that were the consequence of pandemics. So while we listen all the speeches, and also Professor Sokol from the Brussels office, he's drinking his coffee. The audience here in Croatia can also serve themselves with coffee while we listen to the speeches. Professor Sokol, the mic is yours.
Thank you very much again. After the introductory speech, I will just like to say a bit more detailed things about the Europe's Beating Cancer Plan and our report in the Parliament on this plan, but also some of the other initiatives which are going on European level, which will directly affect healthcare, health outcomes, and the problem of inequalities in cancer care. So when we speak of the Europe's Beating Cancer Plan, so as I said, it covers all phases of fight against cancer. So from research, prevention, early detection, treatment, to aftercare and afterlife of cancer survivors. So when we speak of research, I would like to emphasize that in the Horizon program, which is the crucial EU program for funding of top quality research, cancer has become one of the priority missions, which means that when allocating funds and making funding decisions on projects related to Horizon, beating cancer will be one of the priorities. And this is a big success for all of us who are engaged in fighting cancer, and this is also part of the Europe's Beating Cancer Plan. Second, the prevention. Prevention is actually part of the Europe's Beating Cancer Plan, where we have I would say, the most concrete and most comprehensive actions provided by the plan itself. And this is the area where EU has strongest competences, actually strongest possibilities to act. Of course, when we speak of prevention, we know that more than 40% of the cases of cancer are preventable. This directly reflects the lifestyles in terms of obesity and eating habits, alcohol consumption, tobacco consumption, use of chemicals, etc. So European Union here is preparing a host of concrete legislative actions in order to facilitate prevention and also to do what it can to reduce especially tobacco consumption, but also alcohol consumption in the European Union. This relates to taxation, but also the rules on advertising, the rules of marketing, especially of tobacco in the European market. So we are awaiting the next month for concrete legislative proposals from the Commission, but we expect that the rules will be much more restrictive and that the European Union will engage strongly in reducing tobacco and alcohol consumption on European level. Also, when we speak of early detection, so screening, so investments into screening, this is something which is extremely important, especially for certain types of cancer. And here, European Union will actually provide a lot of help, including a lot of funding to the national level, so that screening programs can be more can be strengthened, and that that the target populations related to screenings of certain types of cancer can be addressed, and so that we have more or less a similar situation in different member states, which now is not the case. Also on treatment, inequalities related to treatment are very important. So here we have different financial possibilities on part of the healthcare systems, so different levels of health workforce. We have definitely a deficit of health workforce in some areas of Europe, especially in Eastern Europe, like for instance in Croatia, a lack of top quality healthcare equipment, different in prices and reimbursement of medicines. So all of these are problems which exist currently on the European level. So what European Union plans to do about this? So I think that Europe's Beating Cancer Plan in that area is really not ambitious enough. The most important action there, which plan consists of, is the creation of European Cancer Inequalities Registry, which is important. But I think we can go much further in terms of strengthening European action related to cancer treatment. So what concrete things that are we proposing on European level? So what is very important in terms of regulation is the question of pharma prices. So the question of pricing of medicines, we know that determining prices and reimbursement is also a national competence. So each member state determines how much it will pay for certain medicines. But unfortunately, different member states, especially small member states, do not have the same bargaining position as the big member states when negotiating with pharma companies about the pricing of medicines, especially of expensive medicines for rare type of cancer. So now two things which are being discussed on European level. First is the joint procurement. So that is the idea presented by the European Parliament, that instead of each member state negotiating individually about pricing of medicines on with pharma companies, that we have a joint European system, so that European Union as a whole negotiates with pharma companies about procurement of medicines in order to increase and strengthen the negotiating position of the member states, and also to reduce prices. So this is the similar idea we use as a role model, the way how vaccines for COVID were purchased. So the idea is to also have something like this, very similar on the European level in terms of purchasing of expensive medicines. Another idea which is floating around, which is being proposed by the pharma industry, which I think is also something that should be discussed, is the idea that the pricing of medicines is adapted to different financial possibilities of different member states. So we know that we have enormous differences in terms of financial capabilities of different member states. So Bulgaria, for instance, and Romania on one side cannot pay this cannot allocate the same funding for healthcare as the Netherlands, for instance, or Sweden. So there is an idea that the prices are therefore adapted to financial possibilities of different member states, and this is also something that is being discussed. So these are the two most important initiatives about what we can do on European level to reduce pricing of medicines and to make them more accessible for national healthcare systems and for patients, obviously. But we will see what comes out of this. Also, this was one thing. The other thing, which is also very important, is funding. So when we speak of healthcare treatment and reducing inequalities, we know that the member states need help in terms of funding for healthcare. And now in this budgetary period from 2021 to 2027, this financial possibilities from EU budget to be spent on healthcare are much bigger than ever before. So for instance, we have the EU for Health program, which is 5.3 billion euros, which is 12 times bigger than the previous budgetary program for healthcare in the previous budgetary period. So from 2014 to 2020, budgetary program for health amounted to 450 million euros. Now the new one amounts to 5.3 billion euros. Of course, this is still not enough. So the European Parliament asked for and wanted more than 9 billion euros. But in the end, during the negotiations on the 7-year budget between the Council and the Parliament, this kind of a compromise was made. A lot of this funding will be spent on strengthening resilience of healthcare systems for future pandemics, also strengthening European institutional framework for this, but also part of this will be spent for implementation of Europe's Beating Cancer Plan, which is very, very important. Also, we have the recovery and resilience facility. This is something which is also extremely important because this is a completely new budgetary instrument, a new sources of funding from EU level from the member states. And healthcare is one of the top priorities of recovery and resilience facilities. We know, and the national plans have already more or less been approved, including the Croatian plan, where we have the funding allocated and a lot of concrete reforms proposed by the member states. So in order to spend this money provided by the European Union, member states have to conduct very concrete healthcare reforms, which they put in their national recovery and resilience plans. And this is something which is very important. And by using this financial instrument, we can also reduce healthcare inequalities which exist in different member states. Also, there is the cohesion policy. These are the traditional sources of EU funding. I already mentioned this. This was the biggest source of funding from EU level for healthcare in the previous budgetary period, 2014 to 2020. More than 25 billion euros was spent on reducing healthcare inequalities from EU cohesion policy in the previous budgetary period. Of course, in the next budgetary period, the amounts will be more or less the same or very similar, but what is important is that we control much more how this funding is being spent on healthcare, and especially whether this actually contributes to improving health outcomes, like for instance, cancer survivorship in different member states. Here, I think we have to emphasize what is important is investments into equipment, especially in national centers of excellence for cancer care, which should be developed according to the Europe's Beating Cancer Plan in all member states. But what is also very important, which is very, I think, specific for Eastern Europe and Central Europe, that is workforce. So we know that we have big problems in terms of health workforce. We have big outflow of healthcare professionals from east to west and to the north of EU. We have like a deficit of medical doctors in some specializations. We have lack of nurses, which is a big problem, for instance, in Croatia. And this is something that we definitely need to fund much more than we did previously. And this is something that I emphasize also in my report on how to use EU funding to reduce healthcare inequalities. So we have European Regional Development Fund to invest in equipment. We also have European Social Fund to invest into health workforce, especially specializations, improving the working conditions, etc. And I hope that member states also take advantage of this, which I think is crucial for the future. So this was about treatment and finally aftercare of cancer survivors. So here the Europe's Beating Cancer Plan also, I believe, does not go far enough in terms of providing and preventing discrimination of cancer survivors, especially when accessing financial services. This problem exists. This problem that cancer survivors need to pay higher premiums than other people because they survived cancer, and this is something which needs to be addressed. Currently, 4 member states, I believe, have rules which prohibit this kind of discrimination, which means that cancer survivors in other member states in a worse position than in these 4 member states where they are legally protected. So what I have proposed, and the Parliament has accepted this in its report, is that we adopt common EU harmonized legal framework which will protect cancer survivors from discrimination when accessing financial services in all member states. And I use this possibility also to call for the Commission to actually come up with a concrete legislative proposal. And finally, the last important initiative that I would like to mention is Europe's health data space. So we have a lot of health data in individual member states on different levels, but this data is not interoperable. It in many cases cannot be exchanged and transferred between different member states, and this is something which hampers cross-border healthcare and also research and innovation. Makes it impossible in many cases to conduct cross-border clinical studies, and this is a big problem. So to tackle this, Commission has come up with a proposal on creating Europe's health data space, which would make it possible to have one common set of rules and standards at European level for both primary use of health data by healthcare professionals, but also secondary use for research. What does it mean? It means, for instance, if you are studying in another member state for 6 months or something like this, you need to see a doctor. This doctor will be able to access all your medical data, all your health, all your patient records, without the need to conduct new diagnostics, new examinations and things like that. So this will definitely strengthen and improve health protection for people who are traveling cross-border in different member states. And this is something which is of utmost importance for the future if we want to have common healthcare standards in European Union. And also this European health data space will also make it possible to exchange data from different member states in the area of research. Also to have much bigger possibilities to use real world data, which is very important, especially for rare diseases where patients where we just don't have enough patients to conduct phase 3 clinical trials. And for this reason, this is something that will definitely be a very big change in the future. I'm glad that I have been appointed rapporteur, the main rapporteur of the European Parliament for this file. I already started working on this, and I think that if we make this work, if we create European health data space where data can be shared and exchanged and used in all member states, that the health outcomes and quality of healthcare will improve significantly. And the very last point also, which is part of the Europe's Beating Cancer Plan, is cross-border healthcare. So European Union legal framework provides possibilities for patients to access healthcare in another member state in which they are not socially insured if they cannot get adequate treatment in their own home state. Unfortunately, these rules which exist at European level of this cross-border healthcare are very complicated, very non-transparent. Patients in most cases are not aware of these possibilities which European Union gives them. This is something that we need to change. So what European Parliament has proposed on my initiative is to simplify these rules to a large extent. Instead of having two different sets of rules regulating the same thing, to actually have one set of rules and to make it easier for patients to access this cross-border healthcare. What is especially important is that patients do not have to pay upfront anymore and then ask for reimbursement, but that the bill is settled between health insurance institutions of different member states. So currently under cross-border healthcare directive, if you want to go to healthcare, to get healthcare abroad, which you cannot get at home, you have to go there, pay for the entire price of the treatment, and then you have to come back and ask from your health insurance fund for reimbursement. So this is a big obstacle for patients because many patients do not have possibilities to pay upfront and then ask for reimbursement. So what we are proposing is to have one common set of rules, which will make this unnecessary for patients, whereby the bills will be settled between the health insurance funds of different member states without patients having to pay from their own pocket. And also what we propose is the right to so-called second opinion. So that means that patients, when they want to access healthcare abroad, when they cannot get adequate treatment at home, that they're entitled to the second opinion from a foreign expert, which is the best possible treatment available in the EU. Because in many cases, domestic experts who provide their opinion are not aware of treatments which are available in other member states. So we want to use European reference networks, which exist, networks of healthcare professionals, to get the opinion of top European experts about where in Europe best possible healthcare treatment is provided. So this is more or less what I wanted to say. So despite this division of competences which exists in the area of healthcare, where EU has limited possibilities to act, we have a lot of these initiatives that exist on EU level. So more funding, more indicators, exchange of data, better access to cross-border healthcare. And if we make all of these things work, I think that the differences which exist in terms of access to healthcare for individual patients will be much decreased when compared to the current situation. So thank you very much. I hope I didn't take too much of your time, and I look forward to hearing other presentations as well. Thanks.
Let's give an applause for Professor Sokol. Thank you so much, and hopefully we will make excellent follow-up of your amazing key takeaways throughout the publication that Health Hub with partners is going to prepare after this conference. So once again, thank you so much, Professor Sokol, and have a nice day in Brussels. Stay with us a while, especially because the next next key takeaways will be from very important partner, European Cancer Patient Coalition, who is more than active in addressing cancer injustice and disparities in cancer care. It was quite interesting to see on the website of ECPC one very, I would say, impressive illustration that for every Elsa in Sweden who has 86% chance of survival following treatment for breast cancer. There is an ILSA and ELSA just across the Baltic Sea in Latvia, Lithuania, with more than 20% less chance. I think the situation in CE countries, especially with maybe a woman named Ivana or Jovana, is also quite similar. She has less chances of survival, and this is something we need to tackle definitely. So a big thanks to Dr. Adela Magyar, Senior EU Affairs Manager of European Cancer Patient Coalition from Brussels. Adela, can you hear us?
Yes, good afternoon from Brussels. Thank you very much for inviting the European Cancer Patient Coalition at this high-level event. It's a pleasure to share with you some of the work of the European Cancer Patient Coalition regarding inequalities in cancer care. I'm not sure I have shared the full screen, if you can see the full screen.
We can see the screen. No problem. With page up, page down, you can control the presentation.
Yes, now.
Right.
I can see now. Okay, so for those that don't know the European Cancer Patient Coalition, where we are the largest European cancer patients umbrella organization, and we will celebrate our 20th anniversary next year. We advocate for patients to be acknowledged as equal partners and co-creators of their own health. And through both our policy and research work, we try to advocate for a Europe of equality, where all Europeans with cancer have timely and affordable access to the best treatment and care available throughout their life. And I have a problem in moving my slides. Sorry about this. We have more than 450 members, not just in the European Union, but also beyond. And regarding social inequalities in cancer, well, this term has been defined for the first time within the guideline produced by the Joint Action on Cancer Control, the so-called CANCON guide. And there, social inequalities in cancer are defined as health inequalities that span the full cancer continuum and involve social inequalities in the prevention, incidence, prevalence, detection, and treatment, but also survivor, mortality, and burden of cancer and other cancer-related health conditions and behaviors. And within the fifth chapter of the CANCON guide, it is stated that regarding social inequalities, that social inequalities exist between European countries, pointing out that in Eastern Europe, the mortality rates for many cancers are above the European average, but also that Western and Northern European countries also face social inequalities in cancer care, such as the low survival rates for lung, colorectal, and ovarian cancers in the UK and Denmark as compared to Norway and Sweden. At the same time, some European countries have inadequate access to surgery, to radiotherapy, and to essential, innovative, and personalized treatments that are very well known to prolong lives. And I will point out some facts and figures regarding disparities in cancer screening. And I chose cancer screening today, given the priority that the current Czech presidency gives to finalizing their recommendation on cancer screening. And one of the very pregnant aspects is, for example, the 5-year survival rate after treatment that is about just 52% in the Eastern Europe by comparison with 63% in Western Europe. Then for cervical cancer incidence and mortality, these rates in Romania from 3 times higher than in other European countries. And regarding breast cancer, for the 5-year survivor in countries like Bulgaria, Romania, and Estonia, the survivor rate is between 75 and 78%, while in the Nordic and Western countries, it's between 82 and 87%. And in this sense, the European Cancer Patient Coalition has launched a survey in 2019, and the survey is called Europe of Inequalities, Social and Employment Matters Related to Cancer Care. And in the following minutes, I will present the most relevant results of this survey that we are currently trying to update and to compare the results with what happened at the national level after the COVID pandemic. So from the very beginning, the results of the survey pointed out the wide social inequalities in cancer incidence and survivor that don't happen just between member states, but also within member states. And yes, cancer is typified by treatment plans, which are burdensome most of the time and have a heavy toll on all aspects of quality of life, with prolonged recovery times in some cases. And yes, cancer patients experience financial toxicity, which originates from lost income, from care expenses, and this financial toxicity can result in an important yet understudied threat to patient and family quality of life after diagnosis and poor outcome of treatments. The survey responses revealed considerable divergence in policy and practice across the countries that we surveyed. And in terms of the cancer disability and the benefits for patients and carers, well, a diagnosis of cancer does not automatically trigger benefits entitlement for patients. A cancer disability, unlike other disabilities, is potentially unstable, and the patient will face cycles of invasive therapy and periods of surveillance, which entails frequent access to medical facilities. And the waiting time, most of the time it's several months for assessment or decisions from assessments, is a stressor for patient, and is mostly emotionally but also financially. Regarding the employment issue, well, despite that we have an EU-wide commitment to equality and human rights at work, the employment rights of people with cancer appear to be very different according to the country they live. And entitlements to paid sick leave are very variable across Europe. A diagnosis of cancer does not prompt a guaranteed period of paid leave, regardless of the severity of the symptoms, of the prognosis and the treatment or the after effects that the patient experiences. And in many countries, those in employment who wish to continue work following diagnosis, or some of them are even forced to continue work due to financial constraints, cannot assume that their employer will accommodate with their situation. And it's the same also for carers. They do not qualify for legal rights in Europe, and at best they can expect a limited amount of unpaid leave. And entitlement to flexible working arrangement for carers is not universal and may compel some individuals to actually leave the labor market even if they don't want to. The self-employed workers are even more affected than the other workers, especially because they are more financially vulnerable than normal employees. And some may be forced to continue working when they are not fit enough to do so. And only a few governments offer support for those that care for a person with cancer. And regarding the pension rights, there is often some government compensation for periods of ill health which have resulted also in gaps when calculating the pension contribution for a cancer survivor. And it's the same applies for a carer. Regarding the financial discrimination against patients, yes, cancer patients and survivors do experience financial discrimination, and in few countries, providers of financial products and services have a duty not to discriminate, but the extent to which compliance with this occurs is really uncertain. And income restriction can mean that cancer patients may be more reliant on financial products and services than other people. So access should not be restricted and terms should not be unfair, mostly because financial toxicity can lead to poorer quality of life and poorer life expectancy. And at the European Cancer Patient Coalition, Dr. Françoise Monnier, who is member of our scientific committee, leads on implementing the law that is so-called right to be forgotten law that aims to ensure the financial rights for cancer survivors. Unfortunately, only few countries implemented this law, namely France, Belgium, Luxembourg, Netherlands, Portugal, and only Romania from the eastern countries. And before concluding, well, a question still remains: can politics lead the way? Can politics drive the change in terms of tackling inequalities? Well, at the European level, we have political will in this sense with the EU Beating Cancer Plan and also the report of the Special Committee on Beating Cancer, the so-called BECA report, adopted earlier this year in the European Parliament. Both come up with initiatives and measures that are aimed at tackling inequalities in cancer care. However, there is some resistance coming from the national level. And for example, I would mention the Council recommendation on cancer screening that is currently aimed to be finalized. It's currently under negotiations under the Czech presidency. Well, some countries still don't consider the scientific evidence for improving cancer screening in Europe. And some countries still believe that member states should improve cancer screening at their national level based solely on their resources or on their capacity. And such approaches do deepen the inequalities that we already have at the EU level. And then if we want to tackle inequalities and implement policy at the national level, we must invest more in health and digital health literacy, both for patients and healthcare professionals. And also to ensure equal access to the high quality cancer care and also to ensure access to a multidisciplinary oncology therapy for patients, we need to implement the creation of EU networks for comprehensive cancer centers that are cited in the EU Beating Cancer Plan. And as also MEP Sokol said before, we need to, cancer patients do need to access therapy abroad, if it's the case, or at least a second opinion. And for this, we need to support the development of information and the promotion of services to facilitate the access to the European reference networks. And in order to ensure that the European reference networks are functionable, we need to ensure that the revised EU cross-border healthcare directive offers a functional framework that allows cross-border collaboration, that allows access to medicines, to therapies and quality medical services, and also that allows prescriptions exchange between countries. And in order to make this type of framework work, we need to have very good cross-border cooperation between the comprehensive cancer centers and European reference networks. And with this, I would like to thank you for your attention.
Applause for Adela and ECPC, and thank you. Your question, can policy lead the way? Let's say optimistic and say it can definitely lead the way. So far, we have amazing initiatives towards to decreasing the disparities, and hopefully in the near future, your contribution also from ECPC as a strong contributor in policy dialogue will be more than important. Thank you, Adela. Stay with us, and looking forward for collaboration with ECPC and Health Hub. Thank you once again. And now, I would say a reminiscence of recent event on the occasion of 95 years of the establishment of School of Public Health in Croatia, which is established by one of the fathers of WHO, Professor Andrija Štampar. Today, here in this room, we have the director of School of Public Health from the School of Medicine, University of Zagreb, and also a member of one of the members of European Social Economy Committee, who were recently with our MEP Carlo Ressler in Brussels, where they presented the vision of Professor Andrija Štampar. Why this is important for today's narrative? One of the 10 principles they offered as a key takeaway of this conference in Brussels definitely speaks about creation of healthier and fairer society, which is more than important for addressing cancer injustice. So let's hear what are the 10 principles they recommended. And we invite Professor Mirjana Kujundžić-Tiljak to share with us their recommendation from the Parliament. Professor Tiljak, the stage is yours, and applause for Professor Tiljak.
Thank you, Mrs. Galic, and thank you for inviting me for today's conference. So I will speak a little bit about the legacy of Andrija Štampar for strong and resilient health systems and the message from the conference we held in European Parliament 2 weeks ago. Yes, so I will just to remind you a little bit about Andrija Štampar. He was born at the end of the 19th century in a small Slovenian village. He graduated in Vienna medicine in the beginning of the 20th century, and very early in his career he was head of the Department of Public Health on the state level, and he was responsible to reform the organization of the public health service in a homeland on that time. In a time between two great wars, he was traveling all around the world as an expert of the health organization of the League of Nations, which is the place where the origin of the WHO idea of his traveling all around Europe, United States, and especially China. And he was also as teaching at the universities of Harvard, Yale, and California. And he is very well known about his contribution in creation of the WHO. The WHO was created in a long period. It took 2 years to create the WHO when the decision has been made. And he was the president of the interim commission. He was one of the author of the constitution of the WHO, author of the definition of health, which is used by the WHO still today. And he was the first president of the First World Health Assembly held in Geneva in 1948. And we can remember still his words on this occasion, and he said that it is obvious that we cannot proceed to the solution of health problems in the same way in all countries. Each country has its peculiarities, and what may be good for one may not be so good for another. But one basic truth applies to all of them, and that is that every individual has a fundamental right to health. When we are talking about cancer patients, we cannot be more we cannot say more truthfully sentence than this, that every individual has a fundamental right to health. The School of Public Health, where I'm from, has 95 years tradition, and we, on that occasion of 95th anniversary, we held a Public Health and Future of Healthcare conference in European Parliament. And what we were talking about there is that Andreas Stamper's legacy is strong and relevant today. Why strong? Because of the relevance of his concepts and ideas. And why relevant? Because of the unresolved problems and burning need for accessible, equal, and fair healthcare. When we are speaking about cancer patients, we can see that very much. So this, he wrote his principles very early in 1926, almost 100 years ago. And what is the importance of these 10 principles? That he emphasized the importance of informing the people. We can remember recently the COVID pandemic and the importance of good information of the people. Then health issues should be dealt with by everyone, not only physicians. When we are speaking about cancer patients, this is very important, that everybody is included in health issues of those patients. As the previous doctor from the patient organization said, if we are talking about financial impacts of the cancer and their employment difficulties, then we can see how this is important, that everybody will deal with health issues. A physician should be a social worker and a public teacher. This is also Stamper's idea, and this is important if we are taking this in the context of cancer patients. The physician must be economically independent of the patient. This is very important issue. And the public health issue is of greater economic than humanitarian importance. There must be no difference between the rich and the poor. When we are talking about inequality, inequalities in cancer patient treatments all around Europe, we are mostly talking about the difference between rich and poor, and this is important that we follow the Stamper's ideas that there must be no difference between the rich and poor in terms of accessible health care. And the main place of physicians' actions is where people live. So this is also important, not laboratories and practices of physicians, but we have to go to the people. We can see it in screening programs. We are seeking for the patients. We are seeking for those. We are trying to, as early as it is possible, detect and diagnose such big illness as a cancer, that then we can act and treat these people. So during the 20th century, Stamper's vision was integrated into all international organizations, especially WHO, and forming the basis of global health standards. So when we are talking about cancer, this is very important to have global and European health standards. And we are also on the direction of Stamper's ideas. It has shown persistence, timelessness, and global appeal. When we are following the Stamper's legacy, it is clear, and these are the conclusion remarks of our conference. So that now and in the future, strong and resilient health systems must be developed by an educated, skilled, and motivated health workforce, which is fundamental to successful health policy and equitable health care. That is, by consequence, essential for the achievement of human-centered health coverage for all and the right to health, as recommended by the Conference of the Future of Europe. The COVID-19 pandemic has exposed fragmentation and dispersion of healthcare provision and funding in many European member states, indicating the need for better integration between healthcare systems on the European level. And this we can also just transfer to the cancer patient healthcare, that we need better integration between healthcare systems on the European health level to avoid inequalities. The European Health Union should improve protection, prevention, preparedness and response against human health threats within European Union and on the global level. So the accent is on protection and prevention and early detection of the cancer. The management of healthcare systems must be considered as a strategically important activity and must be implemented in a multi-sectoral way, considering different perspectives and priorities. My preceders were talking about this. It is necessary to consider the development of digital technologies. So I don't have to explain how it is important that we consider the development of digital technologies and innovation, especially in the early detection, treatment, and rehabilitation of cancer patients. And because we would like to facilitate opportunities for creating new work environments and settings in which healthcare is delivered. The special attention should be paid for the better availability of health promotion, disease prevention, early disease detection, treatment options, and rehabilitation in local communities. And this is also the way to fight against inequalities, to be good in all areas, all around the Europe. That everybody has the same right and same accessibility to the healthcare. Then we can focus on sufficient investment in primary healthcare. The primary healthcare is really crucial. And in a process of early detection, of early diagnosing the cancer patients, the primary healthcare is crucial. And we have focus and invest more to primary health care and also enable good education of the needed health workforce that could help adequate healthcare intervention, especially in this area. Of course, effective leadership is also crucial for managing health professionals at all levels. It is a complex and highly valued component of healthcare provisions that is increasingly recognized as essential to achieving high standards for medical education, research, and clinical practice. The COVID pandemic emphasized the crucial role of preserving the mental health of the population and healthcare workers. And this is also very important if we are talking about the cancer patients. I don't have to explain to everybody how important it is to have to preserve the mental health of all of us. And at the end, the last conclusion was that according to the definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, so we have emphasized play testing on preserving mental health and prioritizing the investment in the improvement of the social determinants of health. And I'm very glad that today was we were talking about the social determinants of cancer and how big impact is on their financial and employment, financial situation and their employment, and how it is difficult for those patients after the successful treatment, after the successful rehabilitation, to come back to the normal life, and how big consequences could be on their entire life, not only health, but also all parts of the health which are here in Stamper's definition of health are included. And I will finish with the Stamper's words. Every individual has a fundamental right to health. If we are talking about cancer patients, every individual has a fundamental right to have, as early as it is possible, detection and diagnosing the cancer, that every individual has the same right to get the same quality of treatment, and that every individual has the same right to get the proper rehabilitation and to be as healthy as it is possible according to the situation of so hard disease, to live in the best quality of life we can provide to them.
Thank you, Professor Kujundžić-Tiljak. We have today upgraded the quote from Andrija Štampar. We heard it at the beginning of the conference. There is no place for first line and second line European citizens. So this is definitely in the same philosophy and manner, such as every individual deserves equal right to the health. Thank you for actually giving us those, I would say, new guidelines for the fairer society and healthcare, which is quite important for our second session named Reducing Inequalities. So we put, I would say, the European perspective from the Commission, from the Parliament. We tackled the issue of recovered and resilient health systems. And now we are going more with more details into the deep, I would say, philosophy of the cancer dashboards, then Cancer Data Navigator from the European Cancer Organization. And we will hear something from FPA also, which is quite important. They prepared amazing publications on weight indicators or the impact of COVID for cancer care. So let me introduce again Mike Morrissey, the CEO of European Cancer Organization, who will cover in more details the topic on inequalities network. And we heard some novelties about the European Cancer Pulse. So the ECHO will be quite active as always, and we have very, I would say, dynamic and exciting days ahead of us. Mike Morrissey, about the reducing inequalities from perspective of ECHO.
Hi everybody, I'm Mike Morrissey, Chief Executive of the European Cancer Organization, and I'm privileged to have been asked to talk a little bit more about inequalities and the role of the European Cancer Organization in addressing inequalities in Central and Eastern Europe in cancer prevention and care. The European Cancer Organization has a network of organizations, pan-European and national organizations, who are focused on different kinds of inequalities in cancer care. And the reason we have that network is that the question of inequalities cuts right across every part of cancer prevention and care. And it's extremely important that we address these inequalities, because it's really not right that somebody who has cancer in Central and Eastern Europe does not receive the same standard of care as in some cases in other parts of Europe, and particularly within the European Union. And the interesting thing about the European Union has been the response to the pandemic. During the vaccination program during the pandemic, there was a concerted effort by the European Union to have vaccines rolled out across Europe all at the same time, starting with people who were most at risk. And this approach of a pan-European tackling of cancer, as well as COVID, seems to us to be a really appropriate use of the European Union's influence. And Europe's Beating Cancer Plan, which was launched a couple of years ago and is in the process of being implemented, is a real once-in-a-lifetime opportunity to make a difference and to raise the bar in cancer prevention and care. At the European Cancer Organization, we believe in patients and their loved ones knowing what questions to ask. Whenever you receive a diagnosis of cancer, you're in shock, you're worried, your loved ones the same. We've developed the European Code of Cancer Practice, which has 10 patient rights, 10 really important rights for patients to know, and their loved ones, of course, who support them through this, and what questions to ask at different stages of their journey with cancer. Sometimes we need to empower patients and their loved ones to ask the right questions to get the best possible care. And it's not really right that somebody who is who's received a very good education, who knows a lot about healthcare, can ask the right questions and get better treatment. We think everybody should be asking the right questions. And if you look on our website at the European Code of Cancer Practice, you can find out more about patient empowerment and your 10 rights. We also think that the pandemic has been very critical in a number of areas. And we're still, and for many years, will be living with the consequences of the pandemic in cancer. For a start, the people who work in cancer, the doctors, the nurses, the pharmacists, the whole oncology workforce is exhausted. It's been a really tough time during the pandemic. Oftentimes, doctors and nurses and healthcare professionals not working on cancer, working on the pandemic. Many people have left the oncology workforce and have gone to do something else with their lives. That's really worrying. And we think that a concerted effort needs to be made to make sure that Central and Eastern Europe has the same quality, the same training, the same opportunities for oncology doctors, nurses and pharmacists as anywhere else in Europe. We were very concerned about the number of people who had cancer during the pandemic and didn't know it. We did a study that 1 million people in the worst of the pandemic, at the height of the pandemic, 1 million people were walking around and didn't know they had cancer. There were 100 million cancelled screening tests during the pandemic. That's huge. So we will be living with the backlog of the pandemic for many years to come. And it will put extra strain on our healthcare systems, which in Central and Eastern Europe in particular, were already under strain and were already not performing to the same level as in other countries. So we believe that the pandemic is a lesson for us in building back better, not just getting back to where we were before the pandemic, but doing much better still, particularly in countries whose healthcare systems were not performing as well as they could have done. Now, how can we do this? And I think this meeting that we're having in Zagreb today is an example of how we do this. We do this by working together. There is no group working in cancer care that can do this on their own. Politicians can't do it on their own. Policymakers can't do it on their own. Doctors and nurses can't do it on their own. Patients can't do it on their own. This is a team effort. And that's why this kind of discussion in this kind of forum is so important for us to agree on what needs to be done in addressing inequalities in cancer care. I'll leave you with one piece of information, something that's very new, something you might want to check out. It's called the European Cancer Pulse. And if you go to europeancancerpulse.org, you'll see data from across Europe. I think it's 34 countries actually. You can click on different countries and find out all sorts of things about that country's healthcare system, that country's ability to deal with cancer, that country's approach based on age, gender, and a whole load of other measurements. So if you get the chance, check out europeancancer.org, and we've got a whole range of data and information for you through our Inequalities Network. I want to finish by thanking the organisers of this event for giving us the opportunity to present. And please keep in touch. If you want to get involved in the European Cancer Organisation's Inequalities Network, please send me an email, let me know. Thanks very much indeed. Bye-bye.
Please, an applause for Mike and the European Cancer Organization, and we will definitely continue to collaborate with them. We support the European Cancer Pulse initiative as always, and we will definitely disseminate the key recommendations for this region. The next lecture is next two lectures are actually related to data and the data utilization throughout the cancer dashboards. And there is a saying that what doesn't get measured doesn't get done. And this is something we need to repeat continuously, especially when we speak about cancer care and disparities that are increased, especially after the pandemics. So we are welcoming Ana Sofia Carvalho from Amsterdam, from University of Amsterdam. She's a public and occupational health professional, and she will speak about the cancer dashboard or cancer care performance indicators, and she will demonstrate a scoping review covering OECD countries. Ana Sofia, thank you for allowing us to share your expertise, and the mic is yours.
Thank you very much. I hope you can hear me well and also see my slides at this time. Can you please confirm?
We're waiting to see your presentation. Just a second.
Okay.
Can you share it? Can you maybe try to share it by yourself?
Okay, I can try to share again.
No problem.
Okay, I think
Great.
now.
Okay. Thank you.
Now it's working. Okay, perfect.
Yes,
Thank you
we
very
can see.
much. Okay, perfect. Okay, thank you very much for this kind invitation. My name is Ana Sofia Carvalho. I'm a PhD candidate at the University of Amsterdam, and it's a great pleasure to be here with you today to share the results of this research work that we have conducted, how COVID-19 impacted cancer care indicators, a scoping review covering OECD countries. This is the outline I will follow during this presentation, and this work that I will present to you is based on a recently published paper at the BMC Health Services Research. The background actually is mostly about what we have been discussing so far, because it was so challenging to monitor the impact of the pandemic in specific in cancer patients and all the other patients without COVID-19 disease. And because we were lacking strong national health information systems, few countries had data that was timely enough for decision-making during the pandemic. And because, of course, if we aim for international comparisons in cancer care, we need standardized definitions and common data models. This is why we conduct this research. This is why we aimed to First, identify and summarize cancer care performance indicators from the literature, and secondly, assess the trends of these indicators on the quality of cancer care that was provided to patients during the pandemic, in this specific case, in the early stages of the COVID-19 pandemic. How did we do this? We performed a literature review. In specific a scope review, we have screened a total of 6,000 studies. After that, we have included in a second stage around 800 studies for full text review. And in the end, in this study, we have included 135 cancer studies. So these were all studies that were studying the impact of the COVID-19 pandemic in cancer care. What did we do? We collected performance indicators from all these studies, and we organized them in categories following the patient pathway, from screening until outcomes. In the end, we had 1,150 indicators, which we were able to organize and also provide some information about what indicators and what were the trends. What did we obtain? First, about the characteristics of the studies. As you can see on the left, most of the studies compared 2020 with the same period in 2019, trying to understand how the indicators changed during this period. Secondly, if you look in the middle at the data sources, most of these indicators were coming from administrative data, as you can see below. But also we can see that 30% of the indicators, this information from these indicators were coming from surveys, which also show us how difficult it was at the moment to collect these indicators from other sources. So international surveys were really a very relevant source to evaluate the impact of cancer care, the impact of the pandemic in cancer care. Which countries were included? As you can see here, around 19% of the studies were international studies, but when we had national studies, all the national studies, most of them were coming from Italy, US, UK, but we had a very good coverage of European countries and also North America and also Australia among OECD countries. What about the indicators? Starting from early detection. As you can see, if we start first, the number of screening, indicator about the number of screening, which was already addressed in previous presentations. So we can see from 33 indicators, most of them signaled a decreasing trend in the number of screening. So this is what you see here as coded in red as an undesirable trend. What about diagnosis? First, the indicator about delays in access to diagnostic procedures. Here again, you can see an increasing delay in access to diagnostic procedures, in this case from a small sample of 9 indicators. What about clinical severity? How were these articles trying to evaluate the clinical severity of patients when they were diagnosed with cancer? First, the clinical severity using clinical and screening some biomarkers and the clinical severity of patients. Second, the cancer staging at diagnosis. And thirdly, the proportion of urgent referrals. And all these indicators, you can see also worsening trends regarding clinical severity of patients when they were being diagnosed. And finally, the number of cancer diagnoses, as we know, of course, as a consequence of all this that was said before, a major decrease and reduction in the number of people that was being diagnosed. Lastly, indicators about treatment. And here we found information about delays in treatment and also indicators providing information about the number of treatments by the 3 main modalities, treatment modalities of cancer. Then we see number of surgeries and local regional therapies, radiotherapy, and systemic anti-cancer therapy. And in these 3 modalities, we see most of the indicators signaling also undesirable trends because they show a decreasing trend in the number of treatments provided to patients during the pandemic. Next, we have outpatient care and specific number of referrals and outpatient volume, also with decreasing trends, and lastly, hospital admissions. And finally, a very interesting finding also, and in this case coming from surveys. When we looked at treatment changes reported, we have found that from 304 indicators, 64% reported changes in treatment performed. So this is information from physicians saying that during the pandemic, they were changing the treatment for diverse reasons, of course, during the pandemic. And this information is very relevant to have it in a timely way and in a transparent way during crisis, of course. So to finish, what did we find? We found a set of indicators throughout the cancer pathway, from screening until the treatment phase. Of course, the outcomes, we still need to see this impact later on in the following years. We found changes in seeking care patterns that were not captured by data infrastructures. And of course, we saw a worsening of indicators across the board. And on a positive note, of course, we have seen adaptation and innovation. What are possible implications for policy and practice? We hope to provide a contribute to identify bottlenecks and also help to monitor the way we are addressing backlog now. And we hope to provide a contribute also to the development of indicators that are really necessary to monitor the cancer care pathway. Of course, for this is necessary to improve the data infrastructure, the linkage among data sets, to monitor continuity of care timely and in a transparently way in future crises. Finally, of course, we need to address some of the limitations of the study. Of course, this was a study that included heterogeneous study designs and indicators, which we had to organize to provide meaningful information. And of course, what about inequalities? So these were indicators coming from articles that in most of the cases didn't have the granularity of data that was needed to evaluate the inequalities. So we do need this data granularity to identify the vulnerable population. So how these indicators changed across these different populations. So we do need this information still. And the final note about the inequalities, we could also see in these articles that the patient perspective was lacking. Most of the surveys were directed to physicians. And of course, if we want to come and to improve our health systems in a patient-centeredness way, we need also to include much more in the future this patient perspective. Finally, I'd like to acknowledge all the research team that was involved in this partnership among the Erasmus Medical Center and the University of Amsterdam, and of course, all the others that have contributed to this work. So thank you for the opportunity to share this research, and my contact is here if you want further information. Thank you very much.
Thank you. Applause for Anna Sofia for amazing lecture, and I would say some shocking key takeaways. Today we have connected many clinicians, representatives of many associations all over Europe related to cancer care, and like the slogan of Health Hub is the point of connection in healthcare. I think that we already see some possibilities of collaboration following those data, because this is something that needs to be more and more highlighted, especially in preparation of post-COVID reaction for improving outcomes after detecting the indicators that you have presented. Thank you once again, and thank you for the Health Pros expertise. And our next speaker is also one of the Health Pros fellow. He's from Croatia, Dr. Damir Ivankovic. While I have discussed with him about the evaluation of one very valuable cancer dashboard that is prepared from CECOG, Central European Collaborative Oncology Group, Damir mentioned that in Netherlands he's covering actually the dashboard topic as something that quite exploded in the ecosystem of policymakers, health authorities, governments in general, healthcare system, and the citizens. So how can we use this dashboard philosophy and utilize it for the improvement of cancer outcomes and reducing inequalities? Let's hear from Damir.
Good day, everyone. My name is Damir Ivankovic. I'm a public health physician, originally from Croatia, these days based in Amsterdam in the Netherlands, and I do research and consulting on health services and systems. I'm really sorry that I could not have been there with you in person in Zagreb or even presenting real time remotely. So I'm making these pre-recorded presentations a few days in advance from a charming German hotel room, as you can see, during the European Public Health Conference in Berlin. Briefly, my work and my research in the last few years has focused a lot on the use of business intelligence tools in healthcare. And for the past 2.5 years specifically, it has been focused a lot on researching the phenomena of these guys. So COVID dashboards, pretty much everyone used some of them or multiple, at least once or many times, and they literally exploded since 2020. I thought it was important and interesting to refocus part of my research work on exploring this phenomena and learning from it. The link to the cancer inequalities, monitoring and evaluating cancer care, I'll try to make it during the presentation, although it will be about COVID dashboards a lot. So the studies that we've conducted in the last 2.5 years, this is part of them. And they were done worldwide. They were done with collaboration of many organizations in different countries. And I'll mostly talk about some of the findings and implications of the first and the last study. The first one was on looking at a large sample, international sample, global sample of dashboards and trying to learn what differentiates a good dashboard from a bad dashboard or an actionable dashboard from a less actionable one. And the last, the fourth study in the list here was one where we talked to people designing and developing dashboards in more than 30 countries around the WHO European region. Before I get into the findings of my research, I'd like to take a minute just to go back to the basics and see what are data dashboards and what are they useful for, what are they good for. So basically dashboards are at a glance, ideally single screen overview of a limited selection of key performance indicators used for making decisions on the topic at hand. They should be a customizable visual tool providing real or close to real-time data, which is sourced from linked databases. As a visual communication tool, dashboards help us distill and understand large amounts of data in a relatively simple way, should allow identification of trends and outliers in data, and basically they should facilitate decision making and communication. So again, a communication tool, a visual tool, those are maybe important things to kind of remember about dashboards. In our first study on dashboards in 2020, we looked at a large set of, I think, almost 160 dashboards in more than 50 countries, and tried filtering what made those that were good, that were actionable, what made them good. And we've came up with these seven features of dashboards that are actionable. The first one would be that those that are developing and maintaining dashboards know what their audience is and what exactly they want to find out from the dashboard and what are the decisions they want to make based on the data they see in the dashboards. Seems obvious, wasn't the case too often, which made some of the dashboards just present data but not really be useful for people using them. Second feature was managing the amount of data presented, so it shouldn't be too much, it shouldn't be too little, and the type of data and the flow of data through this visual tool. Third one, again, seems obvious, but surprisingly not too common, was making data sources used and the methods for analyzing data transparent and clear. Fourth one would be to report time trends, so that's not necessarily data only for one moment in time, but time trends, and potentially in relation to decisions. This was the case for COVID, but I mean applicable to many dashboards. Same as fifth feature, which was providing data closer to home, which would basically imply that this is data which would be relevant to people. In case of COVID, this was more geographically granular data. In case of a dashboard, which would be, for instance, one on monitoring and evaluating cancer care, this would be providing data, if a hospital dashboard, providing data for that hospital, potentially benchmarking with other hospitals. So basically data close to home, meaning data that is relevant to the person using it. Sixth one again was quite important, as we know that COVID did not hit everyone equally. Same with cancer. So being able to break down data into relevant population subgroups is quite important, because if we generalize, if we aggregate all the data, maybe the learnings and the decisions we can make from them aren't as relevant. The last one, as I said, as a visual tool, dashboards should use visual storytelling and visual cues in many different ways to basically ease the understanding and use of data. In the study where we talked to dashboard developers from, as I said, more than 30 countries in Europe, we've learned that these were some of the main themes that developers thought were important for a dashboard, that to continue using and developing dashboards, we should take these into account. And this is a dashboard, again, should be simple, should be trustworthy. So using open data, reporting on sources, reporting on methods, but also reporting on errors that might happen, establishing partnerships with users, understanding their needs, but also in case of COVID, it was with media, ensuring high-level endorsement for the dashboard, so that dashboards can be a grassroots initiative, but they would need kind of a political or high-level managerial endorsement to really be part of also the data communication infrastructure. Software is important that's used. We'll get to that in a bit. Data which feeds into the dashboard is also, of course, important that it's of sufficient quality. Also, dashboards on the day they're launched, this is when the next stage of their development starts. So dashboards should keep evolving with time, should keep adding new relevant data, maybe removing some of the data which is not important anymore. We also asked dashboard developers how they saw, COVID dashboard developers, how they saw future of the COVID dashboards. And basically we identified these a couple of four non-mutually exclusive scenarios for what will happen in the future. This was a year ago when we did this study. Talking of COVID dashboards, developers saw that they are going to be continued updating in the way they are currently, but also there were some further improvements to them in terms of design and data and kind of user elements. Also, dashboards were predicted to be developed with the current expertise and competencies that were kind of gathered during COVID for preparedness planning for next public health emergency, next pandemic. But most importantly, I think for this case is that the competencies of the teams that has been developed worldwide on using dashboards in healthcare and in public health should and will also in the future be used for non-COVID uses. And one of the use cases that was mentioned after were dashboards on cancer, monitoring, evaluating cancer care. And we already see this happening in some countries in the world, and I guess this is quite a relevant finding and implication from basically something that seems maybe slightly less linked and relevant: COVID dashboards, cancer dashboards. To wrap up, maybe just a few potential lessons for both developing cancer dashboards in the future, but also for using them. Not all dashboards are created equal. There are good and there are bad ones. And also as a visual storytelling tool, there are also ugly and beautiful ones. So that should be taken into account. And maybe some of these features, maybe some of these research findings can aid developing nicer looking and nicer functioning dashboards. So it is important to keep to know what the purpose of the dashboard is, what is it used for, to keep it simple and to keep it actionable, meaning that it's fit for purpose, so that it really measures and shows what we want to know about, but that it's fit for use, so that the data that we see in the dashboard allows us to make decisions and act. Users are also important, so knowing the target audience for the dashboard and knowing how will they use the data, how good are they at understanding the data that is in the dashboard is also quite crucial. Teamwork is important. Better dashboards have interdisciplinary teams, have communication experts, have visual storytelling experts involved, have geographers involved, of course, next to clinicians, epidemiologists, data people. So an interdisciplinary team for a dashboard as a visual communication tool is quite important. Data is important. And in order to make dashboards sustainable, they should be integrated as a part of the existing data infrastructure, and they should be integrated within routine data collection and analysis processing workflows. Dashboards use data, and it should be data of good quality, but also they help data collection and analysis get better because we can see how useful the data is and then make changes upstream, basically based on the use. And again, what we found out often is that what software you use for your dashboard matters. The approaches are of using commercially available software, of developing it de novo, and there's quite a bit of experience there. Slightly over time, I'll stop now. Here are my contacts. I'll be happy to receive any questions, comments, and wishing you a great continuation of the event. Bye.
Applause for Damir and his presentation. I remember during one session at the European Health Forum Gastein, the cancer dashboard was one of most important topics in a dialogue between the European Commission, patient representations, industry representatives, etc. So it is good to be introduced and see the opportunity. How can we actually track throughout the dashboards the improvement of reducing cancer care inequalities? And when I speak about the industry, I was pleased that MAP Sokol mentioned that there is no, I would say, inequality dialogue unless the industry and patients are there. So taking into consideration the fact that FP Oncology platform was amazingly active throughout the pandemics, and they created so many fantastic publications that were, some of them like a Bible of data for the cancer care disparities between the member states. It is my great honor to introduce Ivana Cataneo, the chair of the FP Oncology platform. And I remember one quote, there is no point of innovation if this innovation cannot access to the patients. So related to today's conference, Ivana, you have the opportunity to say what your report can say about the cancer care and why really every day counts. The stage is yours.
Thank you, Anita, and thank you all. Hope you can hear me. Make a sign.
Yes, we can hear you.
Okay. And really, thank you for having me here today. It has been super interesting and really always super useful when you gather all the stakeholders around the table. I am Ivana Cataneo from Novartis, and I am the chair of the FP Oncology platform. It is a disease platform within FPA where we have a clear vision. So our vision is that every patient in Europe has access to the cancer care they need, and all our policy work goes in that direction. As Anita anticipated, yes, we did produce over the years several research. They are all available. You just go Google the FPA website and you find that. I'm going maybe to use some of the finding today, but also pointing data are important, but it's also important to discuss what do we do once we have this data, which are the solutions that we can put forward. So on cancer in general, I'm not going to repeat, you heard already earlier today, it is becoming the leading cause of death and disability across Europe. What is important to remember is that cancer is really a societal issue because it is a disease of the aging as opposed to be a disease of the age. So it really takes people in the prime of their life when they are building their family, working. So, and it has not only a profound effect on the individual, on future well-being, on family stability, but also it has a domino effect on economy. And this is where I was really pleased to see policymakers at European level realizing that and putting forward the cancer plan and the cancer mission. There are some good news. So thanks to scientific advances, more people are being diagnosed, but more people live longer and with a better quality of life. And in fact, as you may see in this Bible, as you define them, the number of cancer deaths has been decreasing since the mid of the 90s. However, we cannot celebrate because there is still a lot we have to do, and especially the biggest monster in the room is inequality. So we cannot consider that we are done, that is a success, until when we have disparity in access to cancer care, to cancer knowledge, diagnostic and treatment within Europe, so across Europe and in the member states. And again, one data illustrative of other you can find in the country comparator report is the 5-year survival in percentage. If I look at it, and you can find this data really, and you can also download and play with them. Take colon cancer, so just one area in cancer. Almost 70% of people are still luckily alive 5 years after diagnosis in Iceland, compared to only 50% in Croatia. This cannot be. I mean, we are all European at the same way, and human being, and that we don't deserve this. Now, why, when I look at medicine, so inequality are bigger than just medicine, but when I look at medicine, why is it that patients don't have access or have to wait so long? In the Everyday Counts report, we analyze the root causes of these delays. They are really multifactorial, and everybody has a place in that. So this delay, they go from late start of application process, so could be on our side, let's admit, on the industry side, but also lack of adherence to the timeline for the process. In some countries, you don't even know how long can it be because it changes continuously. Or multiple layers of decisions, so national level, regional level. Lack of clarity on evidence requirement. What is it that we need to produce to assess the innovation that we are bringing to the market? Misalignment on the value and therefore on the price. But there are situations where even when we agree on the value, on the price, then there is no budget. Last but not least, the low frequency of clinical guidelines. So even when everything goes well, if the medicine is not in the guidelines, then physician cannot prescribe. However, the biggest cause of delay, it really goes back to the suboptimal healthcare infrastructure. We all know that even when a medicine is available, it doesn't mean that a patient can access it. Most access issue can really be traced back to the way healthcare is organized. And we heard MEP Sokol earlier today saying this is a competence of member states, fair enough. But the way the healthcare is organized in each member states, it really goes from where is the hospital, the difference between a rural area and the big town, how many doctors are available, how is the care path really organized. Each country have different situation, and that's why different solutions need to be found. So it's not an excuse, it should be like an invitation to go country by country and find the solution to these access challenges linked to the infrastructure. And there is no European intervention or law that can regulate that. Yes, there are European funds that can be leveraged in order to improve the infrastructure, but then again, country by country. In the reports that we mentioned and that Anita mentioned, you can find many of these examples and data and solution. For the session today, I want to point to 5 areas where we think we can work together and really advance and accelerate the time to patient access. The first one is research, because cancer, as you know, in cancer, 60% of cancer are not preventable. There is agreement around that. We can do a lot on prevention, but as much as we do everything on prevention, still 60% of cancer are not preventable. So we need to continue to invest in research. There is a lot we don't understand yet on how the disease works. And to that, we really need Europe to be at the forefront of innovation. Unfortunately, today, we see that we are losing ground versus other parts of the world in terms of clinical trial, in terms of advance. And this, again, it's creating an inequality already at the start. To that, we need a regulatory system which is fit for purpose, conducive to innovation, predictable, agile, and quickly adapting to the pace of, to the speed of science at the end. Then we need to improve the sustainability, that's my second point, of the healthcare infrastructure. it's really time, we know a lot, we talk a lot, it's really time to take a courageous decision to prioritize investment in healthcare and drive bold systemic reforms to break what I call the devilish loop. Take the CEE governments, they tend to invest less on healthcare as a proportion of their GDP compared, for example, to the EU5. But then when you invest less, you get back less. So life expectancy, unfortunately, is 5 years less than the EU5 average. It's a devilish situation. So poor investment in health translating poor health outcomes, which normally tackle people in the working age. So this leads to economic loss and the need of more money to go into healthcare. We have an historical opportunity in this moment, going back to what was said this morning, what the European Commission is doing, the parliamentarians are doing, there are funds. So now it's really the moment for member states to take this courageous decision and redesign, modernize, and put investment in their healthcare. Also thinking to data and digital, there is a recent report from Deloitte that says that with a better integration of data and digital, up to 400,000 lives could be saved annually in Europe. Third priority, accelerate time to patient access, change mindset. I have two examples here on how already now, without doing too much, we can accelerate. One is on the regulatory process, and we saw it in COVID, so we have to capitalize and learn out of this. There is a part of the process after EMA approval and between the European Commission gives market authorization for companies to, and again, I'm talking medicine, so for us to start the tour of the country to give to discuss access. This process lasts, by law, it should last 67 days. Sometimes it lasted up to 198 days. Nothing happened on science during these 67 days. It's just office work, translation, let me put it that way. But these 67 days, they come at a cost. In an analysis that we did, that you will find if you go into our website, these 67 days on 11 recently authorized oncology medicine equals to 18,600 years of life lost. Now, this is an insult for the patient, but also an insult for the citizen. Nothing happened on a scientific level in these 67 days. And in COVID, we saw it was 1 day. So there is something, while the European Commission is now considering revisiting and changing the pharma legislation, this is a low-hanging fruit, something that can be really done quickly. On the other side, we celebrate, that's a second example, the HTA, the new HTA regulation. But there as well, if for us it was a big success for patients because we all see how we can speed up things. But there as well, if there is not a change in the mindset of the member states and going through a truly harmonized HTA criteria and really keeping what I have today, just adding up to the other countries. So no harmonized, but more a sort of amalgamation, that will translate, again, this is another study, in something like, we will be required to do something like more than 800 more analyses when we submit innovation for value assessment. And this will increase time, so it's going exactly in the wrong direction. And there is something that can be fixed quickly. I mean, it doesn't take rocket science, it's just a matter of change mindset and agreeing and considering, yes, we want to accelerate and tackle inequalities. The fourth point where it will be interesting to discuss and find a solution together, it's really on developing tailored pricing and reimbursement model. At member states level, this can happen with novel pricing and payment model where we can manage the uncertainty, the clinical uncertainty, the budget impact and sustainability, but at the same time give access to patients to what they need and reward innovation. European level, it will be enough if they can work on the two examples I gave before. And from the industry side, as MEP Sokol mentioned, we put forward 3 proposals. One is our commitment to file for price and reimbursement within 2 years after the Commission central authorization, hopefully reducing the famous 67 days as well. A portal to track transparently not a dashboard, but really a portal to track where we are and sharing things that are going well and challenges that we are encountering, so we solve together. And then a pragmatic framework to equity-based tier pricing, because Europe, it's founded on solidarity, and equity-based tier pricing goes along the line of solidarity. The last part is really on collaboration. We have the European Beating Cancer Plan and the Cancer Mission, which can really be a test case on how we are able to collaborate. Cancer can also become a sort of an inspirational blueprint for the other disease area on what success look like across Europe. The Cancer Plan with its inequality registry, the European Cancer Pulse that FPA and ECO work on and that will be launching this day, they have the potential to demonstrate that the health inequalities challenge can be tackled and overcome. So to conclude, sometimes I'm really thinking, we know what we have to do. We share a common goal. We want to reduce the burden of cancer on individual and society. We made a lot of progress altogether, but we are not there. We do all believe that faster and more equitable access across Europe is an achievable goal. We all share that goal. We just really need the political willingness from all sides to go in that direction. These big steps towards equity are needed. Otherwise, really, we cannot speak about Europe. It's simply not acceptable, as also other speaker before me said. And nobody can do this alone. The issue is multifaceted, it's big. So only if we work together, and here for us, collaboration is really an imperative. We can look holistically at the barriers for patients and find solution, workable solution altogether. And really looking forward for the continuation of this conversation today, because there is so much we can do together. Thank you, Anita.
Thank you so much, Ivana. Applause for Ivana. And I will consider this as an invitation definitely for continuing our collaboration and for further dialogue and joint action between the stakeholders, especially in this region. And just to highlight, IAG report is tremendous amount of so much valuable data to compare the discrepancies between the East and the West, and we still have a lack of knowledge about this report here and everything that you offer throughout the Everyday Counts publication. So we need to communicate almost on a daily basis, as we said, but let's keep this for events to come and publications to prepare together. Thank you, Ivana, once again. And the last lecture in this session between the panel is, I would say, the clinical perspective and the impact of pandemic on the clinicians, oncologists in this region. We have an honor to, we have connected Professor Stjepko Pleština, the president of Croatian Society for Internistic Oncology, and for past few conferences, congresses of the internistic oncologists, this is probably the topic that you mentioned many times, how the COVID pandemics left an impact on cancer care. But what is more important, how can we use this as a lesson, and what is your perspective as a clinician to offer for the countries in this region, for CE countries? Professor Pleština, can we hear you? Oh, we can hear you. Great.
First of all, I want to thank you for the invitation. As a clinician, I'm particularly pleased and happy that oncology has become a subject of interest at a high level, and the fight against cancer is recognized not only as a national but also a European priority. It's very well known that the incidence of malignant disease is higher in more developed west and north parts of Europe than in the east and south. But in contrast, mortality is disproportionately higher in the east and south. In terms of the incidence of malignant diseases, Croatia is approximately on average in the European Union, but in terms of mortality, we are among the leaders, second only to Hungary, sorry. We have been trying to change that for years, but so far we have had little success. Then COVID appears, but that cannot be excuse for us. There are several reasons for the high mortality from malignant diseases in Croatia. Recognized risk factors such as smoking and obesity are insufficiently avoided. The disease is detected as a more advanced stage when the expected outcomes are for sure worse. It's also necessary to work on the surgery, on the quality of surgery. It seems that we have too many recurrences of the disease, even in patients with an earlier resectable stage of the disease, because they have not undergone radical surgery. A special problem is radiotherapy in Croatia, where the available capacities are absolutely insufficient. The availability of innovative drugs is relatively satisfactory, although it is certainly difficult, and every day it will be more difficult to follow daily progress and find funds for increasingly expensive therapeutic options. So at this moment, it is difficult to say what the consequences of the pandemic will be. One should be careful because the analysis of epidemiological data is demanding a long-term process. According to the available data, it seems that in 2020, there are about 10% fewer newly diagnosed cases in Croatia, which would make us happy if it weren't for pandemic. This means that there are fewer diagnosed cases due to COVID. However, still, 2020 mortality continues to show a downward trend, so it is questionable how this will affect mortality in the next years. Of course, we are afraid that this means that the disease was discovered at a later stage, which then means a worse final outcome. But I repeat, one should be careful in the interpretation of data. For example, 14% more patients were treated in my institution in 2020 than the previous year before the epidemic. That was probably because of overflow of patients, considering that some hospitals were more dedicated to COVID infection. And additionally, of course, the earthquake in Zagreb also had a significant impact, which deprived us of significant hospital capacities and caused major additional problems in addition to the epidemiological situation. However, with great effort, we managed to achieve that there were no significant delays in work and treatment. The patients who were diagnosed and in treatment process, there were no major delays. We had to learn quickly. We have never had such a situation before. In the shortest possible time, we gave guidelines both at the European level, for example, ESMO, European Society of Medical Oncology, and at the national level. We have seen that we can connect well and collaborate even virtually. We facilitated access to oncology care by removing administrative and territorial barriers, which was particularly significant at a time when travel was not easy. So both our patients and healthcare professionals somehow benefited from the whole problem. Of course, the problem remains that access to healthcare was difficult, especially to family medicine doctors, so that some patients did not even present themselves to oncology institutions. And at the same time, there were problems with diagnostics, especially endoscopic ones. Although patients with malignant diseases were declared a priority, there were also problems with surgical oncology. However, we have yet to see what consequences this will have. Namely, this can be significant in some types of malignant diseases, but not in others, depending on the kinetics of tumor growth. There were also delays with early cancer detection programs, but we managed to make up some of the backlog. So if we talk about Croatia, both sex combined, colorectal cancer is the most common newly diagnosed cancer in Croatia. A program for the early detection of colon cancer exists in Croatia, but due to poor response of the target population, it has not yet produced the expected results. The pandemic probably contributed to this, among other things. However, it's not acceptable that, as mentioned before, in Iceland, 70% of patients survive 5 years after the diagnosis on colorectal cancer, and in Croatia, only 50%. It's quite clear that we are doing something wrong. It's obviously the last hour to do something in order to give our citizens a chance. So we have yet to see what the final consequences of COVID will be. The epidemiological picture at the national level will only tell us in a few years. The data for 2020 cannot be considered relevant, and just 22 versus 29 as a final result. The effect on mortality will be shown only later. We talk a lot about stage migration, detection of disease in a more advanced stage, but we will have to wait a little longer for such data. The problem is that due to poor reporting in a large number of patients, our National Registry for Cancer does not even record the stage in which the disease was diagnosed. I hope that the implementation of our national strategic framework against cancer will bring about significant system improvements and ultimately color outcomes. The implementation of minimum accreditation standards is necessary, as well as a clear definition of the oncology network of institutions and their connection. For a number of years, we have had an epidemiological database, but not a clinical one. So we cannot monitor numerous relevant data at the national level, only possibly at the institutional level, but with some biases. So in addition to organizational, the pandemic has caused great financial damage to the health system. A huge amount of money was spent on vaccines and medicines, as well as on protective equipment and other things. However, COVID should not be an excuse for us. We must use additional forces in order to improve the outcome of the fight against malignant diseases. I hope that the implementation of our national plan will soon change the current unfavorable situation in Croatia. Thank you for your attention.
Thank you, Professor Plešina, for your kind contribution and key takeaways, and surely we will continue to strengthen this dialogue in Croatia on your further events of the Croatian Society for Internistic Oncology in Health Hub. Of course, you have our full support. And this actually gave us excellent, I would say, intro into the one of the dynamic parts of today's event, panel session. Although we have a slight delay in time, we are one lecture less than expected, so we will probably finish in time. I'm inviting a very dynamic team. We have some people online, some people here locally in Croatia. So let's give a warm welcome for our online guests. We have from Romania, Marius Ganta from Inomed. Please an applause for Marius. He will introduce later on. Then we have Professor Eliashko Arabadziev from Bulgaria. Applause for Professor Arabadziev. Here in Croatia, please join us. We have here the president of coalition of the patients, Professor Ivica Belina, who is very engaged here in the local ecosystem, but also regionally. Also here we have Assistant Professor Fadi Al-Maharik, a neurosurgeon who will speak about the disparities in neurological cancer. Professor Al-Maharik, welcome. And we have online Professor Marko Jakopovic, who is from the University Hospital Center Zagreb, the chair of Department for Lung Cancer. Professor Jakopovic, can you hear us?
I can hear it. And I hope
Okay,
you can hear
that's
me.
great.
Yeah, great.
Professor Arabadziev, can you hear us? And Marius?
Yep. Can you hear me?
That's great. Let me just... Can you hear me on the mic, all of you? Well,
Yes.
we will make a promise for next time to enjoy in the beauties of Croatia and organize some high-level policy forum face-to-face in the beautiful Dubrovnik or somewhere at the beautiful part of Croatia at the coast. But first, let's actually say a warm welcome to Bulgaria and Romania, and maybe to allow to present themselves. Professor Arabadziev, you have heard your colleague, Professor Pleshtina, who is also an oncologist, about the challenges of cancer care and disparities among CE countries. Maybe just a short introduction of your expertise, Professor Arabadziev.
Thank you very much, Anita, and thank you for this kind invitation. I'm honored to present here together with my distinguished colleagues. In fact, I would like to congratulate all presenters who present data so far. It was a very accurate display of the problem of inequality of cancer care. Representing Bulgaria, which is unfortunately one of the poorest countries in European Union, this topic is a very burning one. Besides being a medical oncologist working with cancer patients every day, I'm recently been elected as a board member of the EU Mission on Cancer to the European Commission. So,
Congratulations.
thank you very much. This is a huge challenge for myself and for my other 14 colleagues in this board of the mission, because you know that both European Cancer Plan, EU Beating Cancer Plan, as well as Plan for the implementation of the mission, they require equal access to treatment of all European citizens with cancer. You are also aware that the goal of the Mission on Cancer is to improve quality of life for more than 3 million of Europeans suffering from cancer by 2030, year 2030. So I'm very happy being here because my personal goal is to make access for Bulgarian and all European and all CE citizens, cancer patients, to the latest improvements in cancer treatment, but not only treatment, but also diagnostic tools, as well as general care for patients with cancer, like palliative care, opioid analgesia, and so on and so on.
Thank you for amazing introduction, and once again compliments for this challenging, I would say, task in front of you, but we don't have any doubts that you will be at the forefront of it. And maybe we should collaborate more often. Here we have Marius Geanta. I know Marius for many years from European Health Forum Gastein, and everyone that are active in health policy ecosystem knows how Inomed and Center for Personalized Medicine in Romania is very engaged in strengthening this, I would say, narrative about the importance of access of innovation in this region. So Marius, very warm welcome from Croatia.
Thank you so much, Anita, for the invitation. I'm very happy to join you actually from Prague. I'm here for another meeting today and tomorrow, and as well very happy because you put this topic of inequalities on the agenda, and this actually give me the chance to link this buzzword, inequalities, with another buzzword, which is innovation. But I think for us, and my colleague from Bulgaria, I think explained very, very well earlier, that for us both are crucial words, because on one side we can all see a big wave of innovation coming in cancer, from prevention to screening to diagnosis and treatment, as well improvement in the use of digital tools and with a favorable impact on quality of life. So there are a lot of innovations coming in the last decade, and we expect that actually this wave to become even bigger in the years to come. But on the other side, we see in our region that each and every innovation in cancer actually increase the inequalities. So I think our task is to find ways to use innovations in order to help citizens and patients, but to use them timely and to use them in a different way, and to make actually innovation the engine for inequalities reduction. I will end my intervention by saying that I have been highly involved in the discussion around COVID in Romania, as well in the region. And what we actually identify in relation with the COVID-19 vaccination campaign is this East-West divide, these inequalities that actually are a reality as well on the vaccination. And vaccination for COVID, we can extrapolate to vaccination against human papillomavirus and so on and so forth. What I am trying to say is that if we would like to reduce East-West divide or East-West inequalities, we should act in a different way. There is no one-size-fits-all solution for the entire Balkans or Central Eastern European countries. And sometimes it's very difficult to find just one solution for a big country like Romania with 8 European regions. That's why it's very important, and I'm very happy to be here today. It's very important to capture the real needs of the citizens, of the patients at the community level, the needs of the medical doctors, as well the needs of the health system and the people working in Balkans and in this area, in order then through European projects and funding to be able to address the real needs of the citizen and the patients, because otherwise we'll act in the same frame as it was before the plan, and not being able to adapt to this new reality actually will put us in the situation to measure, to have very nice data that will show actually that inequalities will increase. So my call to action is to come together to build maybe a Balkan Cancer Mission. We have a big expert with us from Bulgaria to link all the relevant stakeholders from the region to make our voice being heard, and especially make the other people from Brussels bubble, from the Western countries, to really understand our needs from the region.
Thank you, Marius. You made us think or rethink, actually, which is also the title of your initiative, amazing initiative, Rethink Healthcare. We will tackle this later on. When you speak about innovations, here we have also online Professor Marko Jakopovic. Although Croatia was confronted with the poor lung cancer outcomes, in some things, actually, when you maybe reach the bottom, then you only way you can go is up. And as actually pulmonologist, Professor Jakopovic, how can you evaluate the courage to for Croatia to launch a lung cancer screening program as the first one in EU, and compare this with the huge disparities in access to some innovative treatments, comparing maybe to Western countries for lung cancer?
Thanks, Anita. Hello to everyone. I think this was really, courageous, but we were preparing this for a few years before, of course, not a few, but a lot of years. And the other issue is that we couldn't wait for the end of pandemic because the pandemic is still ongoing. It's not so bad anymore, but it's still ongoing. So I think that was the idea to start this program. I think this is a great thing that Ministry of Health support us and put this program under their shield and introduce all the other parties which are interested, like general practitioners, nurses, physicians, patients associations, to present this program. And so we did it really good job, I think, for this pandemic 2 years. And the other issue is that I think that we managed to persuade the government and Ministry of Health that it's probably cheaper to do the prevention and early detection of lung cancer than to introduce expensive drugs at the moment. I think this is not a good thing to hear from the drug companies for them, but I think it's better for the patients, because despite these great innovations, I'm thoracic oncologist and I'm doing lung cancer, so we have biggest probably improvements in oncology in lung cancer in the recent years in targeted therapies, immunotherapies, but still the lung cancer is still the biggest killer among malignant diseases. So idea was to try to do the stage shifts to earlier stages. And because when we have a patient in stage 1 and 2 with lung cancer, they can be cured. So that was our idea. So I think what you said, when we push the button, the only way is up, and we managed to do it not only with the pandemic, but we have the earthquakes and everything. So, but we still managed to do it. So I think we are on course. So we screened more than 10,000 people. I think you will talk about it later, a little bit maybe more, but I think we are satisfied. I think that we will save lives with that and try to decrease the mortality of lung cancer for 20% in the first 5 years of the program. So I think this is something which is good, and I think everyone who were doing and help us with the development of the program, and all the colleagues nowadays who are conducting this program all around the Croatia.
Thank you, Professor Jakopovic. As a pharmacist by profession, I really believe in the value of innovation. When you mentioned drug companies, is this situation, Professor Belina, timely investment into the prevention, is this finally the opportunity that the patients who really need access to innovation, through innovations that can save their lives or prolong life, ensure quality of life, especially in the CEE countries, because we obviously have a problem with access according to weight indicators, etc. Is this good to not consider this like independent islands? Okay, this is prevention, okay, this is treatment, but try to connect and finally see the joint interest, even for the companies that are bringing innovations, for the health authorities, for the patients, especially in this region?
Well, first of all, the cancer is unjust for itself, and it's different in every person. And then again, we have a very different situation with different types of cancer and different kind of diseases all around, and how treatable they are. So if we talk about cancer injustice, it exists by itself. And then I think that prevention and treatment are actually equally important, and we should do both, have half and half, because yes, we need to do prevention, but it will change the picture in 10 years and radically change the picture in 30 years. But what's with the people that are diseased right now? So we need to think about them too, and we need to humanize the healthcare to care for their needs.
Thank you, Professor Belina. Fadi, we know each other for many years, and I always respected your efforts to somehow educate yourself in the field of health policies, which is quite important, although you probably enjoy much more in surgery of the brains. But how do you feel when you see so many innovations that are offered in the field of oncology, especially in your field, for instance, glioblastoma, etc. And you cannot at this point offer this kind of treatment because it is not accessible here due to the budget issues, or you don't have equipment that is necessary for this. You're not capable to do this technique in your hospital and you go to Dubai or you go to the UK and you can witness amazing results and outcomes.
Yeah, thank you, Anita, for your invitation. It's my pleasure to be here and to talk about the tumors from the different way that I'm thinking about. I'm a neurosurgeon, so I'm dealing with tumors intraoperatively, and when I'm traveling all over the world and see our congresses, neurosurgery congresses, we are always talking about how to treat the patient and how to take this tumor out from the brain. This kind of thinking that we have, like a neurosurgeon, I was surprised first time when I went to UK, when I saw the first meeting with the consultant and the residents and the nurses and the oncologist and the psychiatrist. I see a lot of people.
Multidisciplinary.
Yeah, but they are talking to the new patient that they found a glioblastoma, and they I gave him a very nice support that I was surprised. More than that, they went to the OR and they saw the equipment that we have here in Croatia. So we have, I can say, we have the most important equipment at the OR, and we can give the best treatment, the best treatment that we have to our patient. And there is a big difference between the operation here in Zagreb and the operation in the UK. But the difference is the cooperation between the colleagues and the support that the healthcare system is giving to the patient. And I think it's not a big deal that we must just organize ourselves to offer that kind of healthcare. It's very important. Why? Because yesterday the patient was like normal. He's playing football or he's talking with his friends, and suddenly something has happened, AP attack or something like that. And we did a CT scan or an MRI, and we found a tumor. So it changed his life 180 degrees. So at that moment, he's confused what I should do. And I think we must work together at that point.
You definitely look at this issue from the perspective of the brain, which is according to your specialization. Thank you, Fadi. Professor Arabadziev, you mentioned a mission for cancer. This is amazing initiative by the Commission, but you definitely can, I would say, work and act much different as someone who is from Bulgaria, who can really see in practice many challenges. So you have a practical perspective of disparities in oncocare, and you can utilize this like a very important scientific and political initiative for the future. How can you see the vision of collaboration between the mission, the scientific community, Commission in general, from the policy perspective, and health professionals to really tackle this issue of injustice?
Thank you, Anita. As you mentioned, I truly consider one of biggest assets of my presence in the mission board on cancer that I'm residing from Balkan area, from CEE countries. I've been active medical oncologist for the last 15 years. In fact, I know most of the people present today in this discussion. We've been collaborating long time ago in different projects. So I'll keep this line of direction when I'm attending meetings of the mission board. Basically, I'm also a member of the working group we especially created and dealing with inequality. And we broaden kind of broadened the definition of inequality. As I said, we broaden beyond simply treatment, medication. We broaden definition of inequality, projecting it toward age, population, gender, or even migration status, because someone in the beginning of the conference said that we are suffering from a huge migration wave coming from south, coming from east side of Europe as well, once the war in Ukraine started. And also in this working group of I'm participating in, we set a goal to give a clear definition of what inequality is, because right now there are a lot of definitions, but I mean, we are not united around one in particular. And also, I propose to my colleagues to work on presenting kind of metric tool, because we need to measure the level of inequality comparing to level of economic growth or economic status of each of the European countries. Once we analyze properly access of European citizens to proper cancer care, then we'll be able to level up cancer care in countries like mine, like Romania, Croatia, and other countries in the Balkan area. And one last thing, we need to quickly progress on creating comprehensive cancer centers, because these comprehensive cancer centers will they will guarantee that standards of cancer care for all European citizens, including Balkan ones, will be the same throughout the whole European Union. So this is the other focus of my work as member of this working group on inequality.
You tackle very important issue, and I promise you this will be a part of follow-up in publication, that you will try to describe that we still do not know how to define inequalities. Yes. So I'm really looking forward to your contribution to the follow-up publication of this event, Professor Arabadziev. Sure. Marius, recently you have presented, if I'm good introduced, the National Cancer Plan in Romania. It was a big event. I have seen it in social media. And I remember that there were several questions about the Croatian Cancer Plan. So my question is, how much is important to collaborate between the countries, to share the best practices and expertise in health policy developments between the CE countries? We can really learn from each other.
For sure, and I will try to highlight the key success factor actually for the National Cancer Control Plan in Romania. And I will start by saying that in June 2019, during the Romanian presidency of the Council, our organization, the Center for Innovation in Medicine, actually put forward the idea of cancer as a priority at the EU level. And we discussed in a big event in June 2019 about this topic. Was very important that immediately after the Finnish presidency of the Council, recommend to European Commission to prioritize cancer and to build Europe's Beating Cancer Plan. And we all know that in February 2020, actually the European Commission announced the start of the work for the Beating Cancer Plan, launched 1 year after, so in February 21. And one of the key success factors was the European dimension. On one side, the Beating Cancer Plan, and not forget the Cancer Mission, who highly influence the Beating Cancer Plan. And I think the Cancer Mission, it's a key, absolutely key research project for Europe. So the European dimension was very important. Second was the Romanian president, who actually asked to have a plan like this for Romania. And I was very happy to be invited in the working group. We worked for 9 months to build the plan. My task was related to innovation and personalized medicine, and as well the links with the Beating Cancer Plan and Cancer Mission. Very happy to say that Romania is the first country in the EU who actually has objectives in the National Cancer Control Plan related to all the recommendations of the Cancer Mission, of course, as well for the Europe's Beating Cancer Plan. The third important key success factor was the idea of collaboration, and I'll put the collaboration on 2 layers. On one side is the collaboration of all the stakeholders coming from professional organization, patient groups, industry, people that are, let's say, the usual suspects. But the second layer, and very important, is that we had almost unanimity on the political level, and this has been seen actually in September and October this year, when the plan actually was voted by the both chambers of the parliament and then promulgated two weeks ago by the president. It's very important that in Romania the plan is actually a law, so has the highest recognition in terms of legislation, and being a law actually is very, very difficult not to implement what it is actually stated there. Of course, we are now looking forward to the Ministry of Health. For sure, they need help in order to build the implementation plan, but this working group consists of around 50 person. Actually, we express our interest to continue our work. So to sum up, actually in 3.5 years from nothing, because Romania has never ever had a cancer plan, we are now in the position to be the second after the Czech Republic who actually updated the cancer plan, and as I mentioned, with a high connection with the mission and Becca.
Compliments for your success in the interest of your citizens. Definitely, as you passed the presidency from Romania to Croatia, I will pass the mic for a final takeaway of Professor Jakopovic. Speaking about sharing best practices, I think you must say you are a little bit proud when you go to some congress and say, but for 2 years we are already doing a lung cancer screening program, and the Commission last week actually gave an opinion for lung cancer screening all over the member states.
Well, of course, we are proud. I think this is rather great. A small country like Croatia, and one of the last who entered the EU, has done so much in this part of the thoracic oncology. So I think this is a great thing, and we are really proud of that. And we have to thank academician Miroslav Samarža, who is the leader of the program, who started the program, and who is the initiator of the program. So, and that's why we are going around Europe, actually, especially in this region for the beginning, and trying to share our experiences to the colleagues and share the first results. I think this is something which is good, and then we'll try to keep up and be the leaders in that field.
Thank you, Professor Jakopovic. And final questions before concluding this panel session for our speakers locally here, Professor Belina and Fadi. The next lecture, Marius, will give us about entering the digital age, like a human touch with a digital perspective. And here we have a perspective of a patient representative and neurosurgeon who entered into the field of robotic surgery, AI-based and AI-driven care, surgical care, but one doesn't exclude another, right? How much is this important for the patient that is confronted with the fact that maybe he's scared he will not have enough support like somebody in, I don't know, Sweden or Germany or any Western country?
I think it's very important on the level of getting new insights and getting new information on cancer, and For that, it's also important for every individual patient, but we need to have this human connection still because it's very important. And when we talk about inequalities, we also need to talk about not only equal access but also equitable access, and this is the word that we need to have in
Equitable access.
Yes,
Okay.
yes, equity is very important in this.
Thank you. Fadi.
I am very happy and very proud that we have a robot in our department, and we are using it a lot. And when we asked permission from the patient to do the first operation with the robot, it was like, oh, is the robot, how to say, tested? That the surgeon will do the operation on the robot? You know, it was a lot of, how to say, a lot of questions, how it will work. Almost 10 years after that, we are doing the operations without any problems, and we are talking with the patient, and patients are talking each to other. So now we don't have this kind of affair. So my message is collaboration. It's very important. I am sure that everybody will do his job best. Me, like a neurosurgeon, the psychiatrist, the neurologist, the neuroradiologist, the public health, but we must cooperate each other because my point of view is different, and the expectation of me, it's different than what the patient is expecting from me. So sometimes I saw it. We are not doing the best operation that you can do because the tumor was very big, so you are not happy with the operation. But when you talk to the patient and explain him everything and give him a big support, he's more happy with the results than when you are doing the best operation and you take all the tumors and you don't talk with the patient, and the patient don't have that feeling that we are so successful. So we must cooperate with the patient and each other to make the picture more beautiful.
So to conclude, it is as equal important to have a maximum scientific approach, access of innovations, new technologies, but also to continue to collaborate to reduce the disparities in health literacy and human touch in basic human communications, although many challenges really exist. But we need to continue to overcome those barriers, definitely.
Yeah.
Okay, please give us applause for all the panelists. Thank you, and I'm so sorry that maybe we didn't have enough time to hear more experiences from Bulgaria and Romania, but this is definitely invitation for Professor Arabadziev and Marius to next time when you arrive in Croatia at the beautiful coast that we continue this dialogue, and I promise this will be very, very soon. Thank you once again for your contribution to the panel session, and I invite Marius to stay for the mic and to actually give us the answer. Can the vision of actually health data connected Europe be applied to the CE countries? When I discussed yesterday with Marius, he said simply yes. Marius, can you describe with a little more words, can Europe and the European Union be really data-driven for the improving of cancer outcomes?
Yes, for sure. So this is my extended answer to your question. And this topic is somehow related to what we already discussed about the inequalities. Because actually, when we published the document during the Romanian presidency of the Council, and we proposed a new vision for cancer in the EU based on data and technology and human touch, we didn't have in mind this area and these new initiatives that will come at the EU level and will influence, hopefully in a better way, the health in general, and I think will create a very good foundation for the use of data in order to reduce the inequalities. And I'm referring, because I already spoke about Beating Cancer Plan and Cancer Mission, and actually data and technologies, personalized medicine, in other words, and innovation are actually are the nucleus of these initiatives. We cannot imagine the fight against cancer without data, without innovation, and without technologies. But we have to have the proper framework in order to able to enable the implementation of these new technologies. And I'm really optimistic looking to the European health data space, the regulation launched by the European Commission this year. And I hope the European Commission will continue, will not be tempted to say that health it's a matter of member states, is their attribute, and the member states should drive this. And because if the European Commission will go this way, actually we will not be ever in the position to see the value of data in oncology, or the value of data in the fight against cancer. So this is the reason I strongly advocate for a unified approach at the EU level, and I think European health data space create a very good framework for primary use of data and secondary use of data. But I think, this is the case for my country, for Romania. I think we should start by explaining why data are so important. Why data should be always used before starting the treatment. Why data should be used by each physician involved in a patient journey. And I think this educational approach is the next immediate step that we should take into consideration, because we are in the cancer area. We already see what genomics medicine means, what big data means, and big data is related to genomic medicine, and it's simply not possible for the human brain, for the human mind to accomplish and to understand all this data, big data and very complex data. So we need algorithm able to analyze this amount of data and to be close to the physician when the physician, the medical doctor, the oncologist propose a certain therapeutical way for a patient. So understanding the value of data in oncology, I think, is the key. Then understanding this, I think we can easily move to the primary use of data and to build protocols and guidelines and the way of working in the oncology, way to connect the comprehensive cancer center and community centers around data, around technology. So we'll be in the position to build the infrastructure, but having first the knowledge on how to use it. And unfortunately, we experienced this in the last 20, 30 years with big investments in the different types of medical equipment never used by medical doctors because of the lack of knowledge on how to use this equipment. So I'm afraid a bit not to invest too much in infrastructure, in data infrastructure, and not to be then able to use it and to reach the full potential of the data. So this is about the primary use of data. On the secondary use of data, I think things are even more interesting because the European health data space actually put the full control of the health data in our hands as citizens, in the hands of the patients, in the hands of the citizens. And we will be in the position to decide where, with whom, and what type of data to share, we'll be in the position to add data coming from sensors or other type of data, or we'll be in the position to delete some data from our electronic health records. When it comes to secondary use of that, we'll be in the position to decide if our data can be used for research in clinical trials and so on and so forth. And this is the reason why I think that data and the new technologies, and especially genomics and multiomics, will influence at a larger scale the way we'll provide prevention in the years to come. Imagine that currently we are not able to put together data coming from all the health determinants. The same for the screening. We screen for 3 types of cancer, hopefully for 6 starting December, but there are hundreds of types of cancer actually defined by their molecular signatures. So we can say that most of the cancer types are not screenable now, but will be, I think, I'm sure about that, in the near future through the use of genomics and data and algorithm, able to stratify the high risk patient for different types of cancer. And on diagnosis and treatment, more and more will benefit from comprehensive genomic profiling, comprehensive omics profiling, single cell omics, and so on and so forth. And so I'm sure that all these waves of innovation will intersect all the pillars of the cancer, from the prevention to quality of life. And what is very important is with this regulation, European Health Data Space in place at the EU level, we, the citizens, will be actually in the control, and this will change everything. I'm sure that we don't have enough time today to discuss about the implications, but imagine that for the first time, based on regulation, actually we will be in the center of all the decisions, in the center of the health system, and we'll be actually able to come together with people like us to build data cooperatives and to ask for more personalized preventive measures, screening activities, diagnosis tools, or treatment. So I think the journey of data in oncology is just at the beginning. And we should, in our region, in Central Eastern Europe, we should be very, very careful and always proactive and able to act in order to not transform data and technology in another innovation that actually feed all these inequalities. So thank you once again, Anita, for the invitation. Very happy to continue the conversation and joint actions in Balkans.
Thank you, Marius. Applause for Marius from Romania, and we will definitely stay in touch, and we will continue to collaborate in your amazing initiative, Rethink Healthcare, and count on the support of Health Hub and Croatian policy ecosystem. And as you said, a data-driven, personalized cancer care in digital age is something that can really bring us from zero to hero. But that is the reason why we received the support for this event also to really showcase amazing data-driven solutions that can really boost, I would say, the goals of many cancer plans, establishment of patient registries, and really improve the outcomes of cancer care in CE region. Today we have a speaker locally here from IQVIA. With us, we have Mr. Igor Lerman, who will speak about clinical outcomes and cost optimization. This is something that the governments like to hear, definitely. Academic and cross-country collaboration. Mr. Lerman, the floor is yours.
So, hello everybody. It's nice to meet you. For those of you who don't know me, I'm Igor Lerman, and as of recently, I'm country lead in IQVIA for Croatia and Slovenia. So today I will show you some very advanced and modern oncology registries which have a goal that they will improve clinical outcomes, bring cost optimization, but also more importantly, or as important, it will enable academic and cross-country collaboration of academic. So for those of you who don't know IQVIA, I will just spend a minute here. We are a company offering a really broad range of services across the entire healthcare ecosystem. We are very well known for clinical trials, for our data and information. But on top of that, we also have a lot of technology platforms. We do consulting, we do market research, and today I'm here to speak about this part of our offerings, which is called payers and governments. And here we have a mix of technology and consulting, bringing really best-in-class solutions implemented by governments across Europe, and trying to lift them to other countries and bring those same benefits. So when we speak about modern patient registries, then IQVIA will be one of the world leader in this area. We have over 100 of registries ongoing at the moment. Over 1,000 sites or hospitals engaged, millions of patients enrolled, and really a lot of patient records. You can see some of the references, but this is just to show you that we really do have a lot of hands-on experience of really how to build a modern patient registry and to answer to the questions on what those registries need to do and what kind of benefits they need to deliver. So if we look into the oncology registries and start to think about them, the first thing is that we need to consider that today they need to be able to integrate many various data sources. Here I have 7. And then as part of this architecture or its core, it needs to provide a support for different data uses. Some of them are obvious, of course, that the main data use is to improve the patient outcome, but also you need to generate real-world evidence. You can generate and support legislation and regulatory. You can support and boost international data collaboration between different clinical centers, to name a few. Also, when we talk about data, stakeholders, technologies, and those aspects, then it's important also to have experience to know what kind of data points you need to connect with which kind of stakeholders and to create what kind of schema. So I have here 4 examples of basically the same data and the same stakeholders, just used in the different combinations and adapting to what is at hand. So if you want to demonstrate the value when you're talking about pricing or discussion between payer and pharma, then you need to have certain elements. If you want to detect a disease, then you need to have a little bit different elements and stakeholders. So I will not go through all 4, but this is the point that experience is also very important to use when you want to combine the data, the technologies and the stakeholders in what you are trying to achieve. I heard today that everybody is wishing for good examples of structured data, interoperable data. I believe we heard earlier in the event, and I'm happy to tell you that these examples already exist. There is 3 initiatives where we are involved, and there are many others, but I will name those 3. So we have an oncology European network, DigiCore, and DataCan. So all those 3 actually have the same thing at heart. It was in all of them. It was the wish was to use already existing oncology patient registries to standardize the data that they have, to standardize their interoperability, and to show that basically by doing that you can build a network covering, for example, in case of oncology network, 17 hospitals, 20,000 patients in 7 European countries. 2 other are DigiCore and DataCan, and I will show you in a second a little bit more about them. So DataCan Central Oncology Registry has 27 hospitals, and again, at the heart of this project is how to professionally simply standardize the data that you use so that it's all interoperable, because remember, all these hospitals have different systems, maybe different methodologies or different pathway for a patient, and always in such projects, this is a key thing to address. If you do it properly, then you can have both clinical and operational benefits. So I will read just a few from the clinical ones, but you can understand the specific patient population in context of the cancer in the real time. You can identify drugs in use and the trends, how they are changing, and which are more let's say, used than the others. You can use this real-world evidence, which was mentioned today as well, as very important, especially for rare disease. You can save a lot of time and actually cost by simply being able to analyze and benchmark your clinical activities across multiple patients or multiple healthcare institutions or hospitals. I also brought one example for you to see that data analysis. This is an example of UK, the Christie, famous Christie Oncology Hospital, and they required an analysis of do all citizens, do they have equal possibilities to have treatment in these hospitals. By analyzing the data and by mapping the patients where they are registered in general practice and how long it takes them to come to the Christie hospitals, they have found that 20% of patients approximately have a less fair pathway and more time is needed or more effort is needed that they will end up in the final destination for a treatment, which is, you will agree, in oncology, very important to be fast and to have the care, let's say, given in an appropriate timing. Another interesting example is the one we are supporting in Germany. It's called ADOREC, and it's a dermatologic oncology group. And basically what is nice to see here that we were able to connect 48 sites and hospitals in the country. Again, like I was saying before, at heart of this problem is how to standardize this data, how to make it interoperable, and how to have a proper quality that what is going in is the data as expected that can bring you examples. Here we are also showing on the right hand side actually how the registry is not designed with the IT logic. So let's build a database and let's put some fields to harness a registry. This registry is actually designed in a patient pathway way. And here on this picture with a lot of boxes and curves on the right hand side, far right, you can actually see what is the patient pathway and outcomes of the patient touching certain points in the healthcare system. One of the challenges which always remain when you are trying to implement technology to improve outcomes in the healthcare is how to have technology properly adopted. And here I would like to highlight that also if you want to have doctors and patients in some cases using the technologies or creating the registries, that you really need to have a know-how, how to design it properly, how to make it user-friendly, how to have it in a convenient place, because this is the only way that it can bring you those results that you want. And for the end, I just want to kind of conclude that it is very important that if you are considering to build an oncology network or have a registries of the data, that you need to think in advance about improvements you will want to make in the future, that you want to support merit-based incentives in those systems, that you want to have ability to have tailored feedback for different stakeholders in the system, whether it is the ministry, the payer, or the hospital. You also want to enable some benchmarking of similar institutions, whether within the country or European-wide. You also need to have a lot of quality checks implemented to make sure that all the data coming into your registry is really up to the quality and ready to be used and to draw some conclusions out of it. And then of course, you also need to start to use this data to come up with some conclusions and action points how to behave more efficient. And with this, thank you very much, Anita and the Health Hub, and wish you a very nice appetite on the meal. Bye-bye.
Thank you, Mr. Lerman. It's quite impressive to see that, for instance, in UK, some hospitals really try to find unfair access to hospitals, and what could we do with the data when we reconsider cancer injustice all over the member states that is really data-driven, like through business intelligence or healthcare policy intelligence. So this is quite an inspiration, taking into consideration the fact that you presented many projects in collaboration with the governments, with the academic societies all over Europe, and this is something that we need to build upon in further communications. Thank you so much, Igor. And based on data-driven care, we heard from Professor Jakopovic how Croatia led first one in the EU lung cancer screening program for past 2 years. And academic Samardzija, together with his team, today Dr. Kristina Krpina and Dr. Ivana Kuhtic, who is there in the audience, they will present how to think as a leader despite some possible cancer injustice, especially when we speak about the biggest cancer killer. Dr. Krpina, the floor is yours.
Hello, good afternoon to everyone. Thank you for the invitation. On behalf of academic Samardzija, please receive his apologies. Due to obligations on our clinic, he's not able to be here with us. During these 10 minutes, I would like to show you some, not only design of our national program, but the 3 main focus for which we are the first one in the world and for which we are pioneers in screening programs. The main components of the program are LCAP guidelines, volumetric analysis, artificial intelligence, GP-based strategy, and digitalization. Just briefly, LCAP guidelines. They are modified for Croatia, and it's based on volume of nodules. As you can see, upon these guidelines, we have positive and of course negative findings. When we talk about negative findings, the nodule volume is less than 150 cubic millimeters and less than 6.5 millimeters. As you can see, in LCAP, we measure average diameter and we measure a volume of the nodule. When we have positive findings, we talk about above 15.5 millimeters and above 2000 cubic millimeters. This is the first one for which Croatia is very recognized in the world, volumetric analysis. When we talk about the baseline, when we perform examination, we measure diameters and we measure volume. But in the follow-up low-dose screening scans, we measure volume doubling time. It means change in volume of the nodule over the time. Why is this? What is the reason? Volumetric is very sensitive. It's much better and much smarter to measure volume of our nodules and not only diameters. When you can see, we have positive and negative findings. When we talk about volume doubling time above 600 days, that means that this report is negative. So the patient or participant returns to the annual repeat low-dose screening tests. But when we have positive findings where the volume doubling time is less than 400 days, unfortunately, this patient has to go to the pulmonologist for the further diagnostic approach. What it does mean? When we have on the first examination and then follow-up, when we measure diameters and when we measure volume of nodules, volume doubling time is automatically calculated because it's structured in our report. So when a report is finished, every low-dose CT scan has a recommendation for the further investigation of the nodule. The second one is artificial intelligence. What is this? Every low-dose CT scan in Croatia goes to the central base for nodal detection. Like I said, every nodal is detected by diameter and by the volume. But before radiologists finish his report, our trained technicians check every and each detected nodule, check every volume, and check every diameter. And when that is finished, radiologists can write his report, and this goes to the structural report. And the third one is GP-based strategy and digitalization. I have to tell you that digitalization is something that is developing in Croatia, but I think our lung screening program is an excellent example how the work is done. This is the, I would like to say, algorithm in our screening program, and it's very smart and it's very easy. Our patient goes to the GP. GP order low-dose CT scan by application, and this when patient perform low-dose CT scan, when radiologist writes his report, the report goes to the CESIC. CESIC is a central health informatics system in Croatia. The same way like GP order low-dose CT scan, the same way this report goes to the GP. When GP reads this report, he has two options. So one option is to refer the patient to the pulmonologist because the report is positive, or if a report is negative, the patient and participant is in further monitoring. Just briefly, 1 month ago, we, Academic Samardzija, and our program were participants on International Lung Cancer Screening Conference in New York. And I have to tell you, not only by design, but by our results, we are the leaders in this field. So you can see in these 2 years, we started in October 2020 till September 2022, we have more than 10,000 scans. Among them, 40% were negative, but 11% were semi-positive. Among these semi-positive, we find 4% positive findings. And among these 4%, we confirmed in 104 patient malignant disease. As you can see, 90% were lung cancer, but we have the other tumors. It's very important to say that radiation dose is less than 1 millisievert. And this is just results we are very proud. As you can see, 50% of these patients underwent surgery. And in this moment, we can say that these patients are cured. Others, 50% were not eligible for surgery, but they are in oncology treatment. And this is, I can say, some exclusive data. This spring, we started with extensive of our lung cancer screening program based on COPD and coronary artery disease. Why these two illnesses? As you can know, according to World Health Organization, COPD and cardiovascular disease are the killers of 21st century. So we have excellent machine, excellent CT machine in our clinic, so we wanted to do something preventive programs for our patients, not only for lung nodules and oncology, but we wanted to do something extra. Regarding COPD, we measure emphysemas, and all of our patients go to the pulmonologist for lung tests. And regarding coronary artery disease, we measure calcification of coronary arteries, and all of our patients go to the cardiologist. It's very important to say that all of our program is paperless. It's very important. This is excellent example for digitalization in Croatia. Thank you very much.
Thank you, Dr. Krpina and the whole team, Dr. Kuhtic and Academic Samardzija and Professor Jakopovic. Is quite impressive to see the paperless screening programs that actually headed from the small CE country with poor outcomes, but this is actually the amazing example how data-driven care can really, I would say, boost the efforts and the outcomes of improving the quality of life and the success of the possible treatment for the patients. So we will continue to promote this as a good example all over, not only Europe, but world when we speak about health policy platforms. Thank you, the whole team from Jordanovac. And as a conclusion, and believe it or not, we came up to the conclusion of today's conference, is the lecture from Professor Eduard Vrdoljak, who was the coordinator of National Strategic Cancer Plan in Croatia. And he gave a lecture about addressing injustice and improving outcomes from zero to hero. What are the costs and benefits of data-driven cancer plan? So let's hear Professor Vrdoljak.
Good afternoon, ladies and gentlemen, dear colleagues. It is my great pleasure and honor to be today with you and to talk about addressing injustice and improving outcomes from Zero to Hero project, about cost and benefits of data-driven cancer plan. To start with, I'm usually defining cancer as the most important medical global problem with this slide, where we are now diagnosing about 20 million cases per year, unfortunately, out of which about 10 million are dying each and every year. From the cancer point of view, again, unfortunately, Europe is very underserved. Europe do have about 9% of global cancer population, but about 20% global cancer mortality. That defines our need to understand the medical problems and requirements that we have to invest in cancer field in order to address that challenges properly. Fortunately, again, Central and Eastern Europe is in the epicenter of problem of disparity of the cancer patients. So when you're looking at mortality to incidence ratio, while Western countries are having larger incidence, less mortality, in our region, we are leading the world regarding bad ratios or number of patients that are dying. Croatia is having a huge cancer problem. Croatia, and we have to give our best to address that issue and to decrease the number of despair, underserved patients, and to improve outcomes by any means. So who is responsible? Patients or we as healthcare providers or organizers? Society in general. Everybody is potentially responsible. From the patient point of view, for example, patients that are older with comorbidities, living far away, are patients that do have more chances to be underserved. On the other side, we have to recognize reasons in the medical system why some patients do not receive optimal cancer care. And ensuring equity and justice in the care and outcomes with patients with cancer is the policy problem. And we have to understand that. It's not science, technological, genetic problem, but policy problem. The best way how to address all those issues is through the National Cancer Control Plan. We have to have a plan to fight against such important and deadly disease health care problem. So unfortunately, Croatia was the last country that developed National Cancer Plan, but potentially was the best. What the National Cancer Control Plan is about is to ensure the best quality of care for the citizens in the country through the resource and timely and comprehensive implementation as well. This is the key of success, to have appropriate implementation of the cancer plan, because almost all countries do have that, but more as a wish list than to have something that would be appropriately implemented. We have worked on this plan a lot. Many people, more than 150, couple of years, foreign experts helped us, and we came up with an excellent cancer control plan. Again, within the cancer control plan, everybody must do prioritization. And we define 3 priorities that we should concentrate on. The first priority that we defined in our Croatian National Cancer Control Plan is investment in national oncology network and patient registries. We understood the importance of data-driven policy improvements. Priority number 2 is to enhance and expedite primary and secondary prevention program to prevent cancer appearance and to diagnose it early, meaning having better outcomes. And priority number 3 is to improve access to modern radiotherapy, because we neglected the radiotherapy field from many points of view. What is extremely important, and what we were very innovative, potentially the first country to do it, we, beside standard chapters in any national cancer control plan, we defined that creation of national oncology network as the part of our plan, and reporting and monitoring as well. But also what we did, we integrated cost effectiveness analysis in order to define cost effectiveness of any measure within the plan. Idea was to ensure that all measures proposed in the NCCP and their respective combined outcomes will lead to a reasonable level of cost effectiveness from both the payer and society perspectives. What we have calculated is that we can save many lives. So, for example, about 7,000 patients could be cured. 5,000 will not develop cancer based on the better education and primary prevention. Altogether, about 113,000 lives can be gained. And when you are calculating the quality of life extended and the price of it, we ended up with 1.3 thousand euros per QALY, or extending the quality years of life with the full quality, what is about 30 times less than it is suggested by World Health Organization. What that means is that investment in organized, structured national cancer control plan is the cheapest way to improve outcomes in oncology care. We are proud that we have published that article, and you can see that this is now widely available, and this is the first such article published as far as I know. So what we are expecting with this first priority of ours is that we will have a major improvement in the fight against the cancer through investment in oncology infrastructure and organization. What do we consider as infrastructure and organization is comprehensive database, monitoring, reporting, and real-world data gathering. So where this idea is coming from is from this paper that we recently published, where we analyze mortality to incidence ratio in comparison to expenditure per cancer case. And you can see, generally speaking, as more you are spending, a better result you are having. But there is one country that is spending similar to Croatia, but having about 10% better outcomes, and that is Czech Republic. And the question that I have and we have asked ourselves is, what is the reason for that Czech paradox? And this is potential answer. So you can see here that Czech oncologists through their database are measuring outcomes. For example, 5-year survival benchmarking for all their cancers. They do have information about stages of diagnosis. They do have definition of mortality and incidence, primary prevention programs, outcomes, so on and so forth. Idea is that through extensive monitoring and reporting, they squeezed best of everybody involved in cancer care. And that is the reason why they are having better results than anybody for the price that they are spending per oncology patient. Just for your knowledge, what would happen, for example, if we are going just to centralize ovarian cancer care in Croatia? Let me tell you the example of and what data can change. So example of Sweden. So what Swedes did, they decided to centralize the ovarian cancer surgery instead of many institutions in couple of them. They performed afterwards analysis of results before centralization and after centralization. What they shown is that after 2011, with centralization, their results improved more than with any specific oncology drug or intervention. 21% improvement in 3-year survival rate cannot be achieved by anything else. So the idea is, with these kind of things, when you are monitoring and reporting, you are able to change for better. This is, for example, another article of ours that we recently published about impact of bevacizumab on outcomes with ovarian cancer patients in Croatia. You can see that after implementation of bevacizumab, the median survival extended for about a year, meaning that the drug is absolutely improving outcomes in for our ovarian carcinoma patients, and that should stay. On the other side, I'm pretty much sure that we would find opposite things, and that is something that we have to do in order to help our patients on the best possible way. So this is the past patient journey without network monitoring and reporting. We didn't see our patient well. We oftenly diagnose them late. We treated by localization. We did have a challenge in access of appropriate drugs. And unfortunately, our knowledge died with the patients and their physicians. Now, the situation is better, and we are starting to diagnose earlier. We are treating better, and we are monitoring better. But the future could be like this. Patient is going to be brilliantly seen, and we will continuously to learn, and we will be able to early and have accurate diagnosis, give every patient optimal care, and learn from every patient. This is the most important thing, to learn from every patient. And based on our digital might now to go forward with huge leaps to make outcomes even better. So there are 4 pillars of modern oncology: patient engagement, cancer panomics, big data, and payment or reform value, that I'm pretty much sure we can do in Croatia and be leaders in the world of oncology. How we can do it is to integrate patient characteristics and information, imaging data, molecular information, pathological data, and available treatment options and corresponding outcomes, and to collect data, analyze data, create insights, and inform practice, and to change way to move in the oncology And with this marriage of digital technology and oncology, I believe we can change the world of oncology. So we would like to spill over our oncology network to EU and to make EU as a powerhouse for change, all based on now European Oncology Network quality control through the reporting and monitoring. Just an example, what happened with COVID is that we published in 2019, at the beginning of the COVID crisis, let's say, importance of optimal management of cancer care through the public health crisis induced by COVID. But unfortunately, what happened is due to the patient and system-related reasons, our outcomes in oncology care were not as good as, and what we are witnessing on the level of whole Europe is that significant number of patients have not been diagnosed in 2020. And recent information from Croatian Cancer Registry also defined significantly lower number of diagnosed patients. I'm pretty much sure that unfortunately we are going to end up with a late diagnosis and that we are going to suffer through bad oncology or worse oncology outcomes again. So now what do we face is that, for example, male in Croatia and Denmark do have a significantly different outcomes, and the survival of Danish cancer male patients are significantly better than Croatians. That is the reason why we initiated grant proposal to EU asking for digital transformation of Croatian cancer care, building a way of life, a sustainable health system, all based on the article that I already showed to you, and our National Cancer Control Plan, all based on that pharmacoeconomical analysis and fact that we believe that this is the cheapest and best potential investment of the money that somebody can do. And we got more than 100 million euros from EU for creation of National Oncology Network, for digital integration of oncology healthcare institutions in Croatia, making us together one institution, treating all our patients as equal, having continuous monitoring and reporting results and opportunity to change continuously, and to equip 6 our institutions with radiotherapy equipment. So they realize that health is not seen as expense, but investment. This is investment of EU in our NCCP because they believe that we can turn down our bad outcomes and make our despair patients with better results. So this is the idea behind that Croatia can achieve Denmark's results and save that 113,000 lives throughout the 10 years. What I'm usually ending up my presentations with is that small countries can do big things, and these are the guys that show us in Russia how things can be done when we are together and when we believe in ourselves. And why Croatia is in better situation than others? Because we represent this small boat that can change the direction fast. And I believe that this is absolutely now the time to do it and to show the world how oncology should and must be organized. And these big boats are big countries, such, for example, US and other countries are, where the systems can be changed rather difficultly. Thank you for your attention, and it was a pleasure of mine to be with you today. Thank you.
A big applause for the lecture of Professor Vrdoljak, who is always really so much inspirational for all of us, especially his quote from Zero to Hero. And with this, we came until the last end of today's high-level policy forum. Apologies for a delay, but this topic is so much important that taking into consideration many other delays in access to innovation, then we can afford a little delay to hear some possible solutions. But at the end, maybe the conclusion that the COVID definitely has served as a magnifying glass for many things, and especially on existing disparities and the economic disruption it caused threatens to deepen those disparities even further. Hopefully with our special policy report and today's high-level policy forum, we will try to address all of the mentioned challenges from recovery and resilience perspective to the concrete measures, data-driven to reduce inequalities. How can we utilize digital solutions and data and BI to support the changes, and at the end to improve outcomes from zero to hero. Once again, thank to the all European community who is online connected, who will watch the recording. Thank you all of you who are here locally today in Croatia. And special thanks to our amazing speakers and panelists. And we hope that all of you have detected some opportunities to find a way how to overcome the barriers. Big thanks to all the attendees of today's event, and let's stay connected for the follow-up, definitely, to join forces with all of the speakers, their associations, in shaping strong Europe of equal opportunities. Also, special big thanks at the end to all of our event partners, because without their support, this dialogue could not be possible and our mission wouldn't be successful. All of you have a healthy, before all, and joyful day. Thank you so much.